Good morning, everyone. Thank you for joining me this morning. I'm so excited to have you. I am so humbled. We have surgeons, some I actually know personally, that are joining us in this course, from around the world. We have people from Argentina, from Spain, from Europe, Canada, so everywhere, and I'm really humbled. As you know, part of this, we're going to talk about a lot of things today, but part of this 2-3 hour conference is that it's going to be, it will include you coming in one day. So we need to plan that way in advance. It includes you coming in and hanging out with me in the OR. I know we're going to cover a lot of things. Couple of things I just want to mention. Number one is, please don't record this, and please don't share this with anyone. You will get access to all the handouts that we have. I have tons of handouts on everything, including the slides that I will share with you. So you will get a PDF of the slides. I will be available for any question and answer at any time. So you can reach out to us, be happy to answer them. So with that said, couple of other things. One is that this material is copyrighted, and I don't want it to be distributed. But more importantly, I have patients that we're sharing today that have given us permission only to be used for educational purposes, and I don't want their videos and pictures showing up online. So I really appreciate you not doing that. Most of you know who I am, but just a brief bio. I grew up in California, and initially I wanted to be a pilot. So I was actually an aeronautical science engineer major at UCLA. And then during that time, I got exposed to microbiology and said, wow, this is the most incredible thing. I want to go become a biology major. And during that journey, somehow my path, took me to medicine, and I got accepted to USC Medical School, so here in Los Angeles, and then did my internship at UCLA and my residency at USC. And because I was doing a lot of trauma, it's 11 level 1 trauma center, I was exposed to a lot of recon cases and trauma cases, and I said, okay, maybe plastics is the choice to go for me. And I was very fortunate enough to go to University of Miami Bascom Palmer Institute and did a 2-year fellowship in oculoplastic surgery. So that's a short bio, and I've been in practice here in Beverly Hills since 2005, so almost close to 20 years. And I will, I've seen pretty much everything from the beginning of, when fillers came to how things have changed significantly from the time I started. So today we're going to cover a lot of things. Most importantly, we'll start with the anatomy. Then we'll talk a little bit about the search for youth and what that entails, and talk about the aging process, since that's a big part of the types of patients we'll be seeing. And then I'll share with you, I want to take you through that patient journey, which means from the time they come to see you, what are their concerns, what are the things you need to look for, what are the things you need to do during the exam, and then we'll go through, what are the instruments you need for the surgery, all the little things that I think are important in you having a, great outcome. And then we'll talk about the actual surgery and what is this evolution of this process, which I call TriFecta. And then once we're done with that, we'll see some, go over some post-op care. We'll see some case examples, bunch of cases I want to cover today. And then we will end with, post-op complications and how do you manage those complications, which I think are really important. So let's get into it. I just showed you this video and it was only 0.3 seconds. And I can tell you that I will promise everyone who watched this video, the first thing they noticed was the eye. And in fact, I would have to give you another 1 second for you to notice the nose and the lips, which are the second and third thing that you will notice. And this was actually recently published on an interesting study. And we all agree, look, we look at each other's eyes, and the eyes are important. The first thing that you meet somebody, when you meet someone, you look at their eyes. So it's a big deal. And we're at an age that, look, everyone's taking selfies, from the grandpa to the 6-year-old, and they're looking at themselves and they're noticing things. They're noticing things that they didn't notice before. So it's probably one of the most important aspects of the face, the eyes. Obviously, I'm biased, but in my opinion, it's true. So let's talk about anatomy. So this is actually a patient I saw in 2002 when I was a fellow at Bascom. And, she had a trauma that, cut half her face. And unfortunately, she went to a hospital that really didn't understand the function of the eyelid, she wasn't initially blind. She became blind after the fact because the team that did her reconstruction really didn't understand the proper anatomy. The first thing you need to know about the eyelids is that the function is to protect the eyes and vision. So it's really important to understand that. So when it comes to eyelid reconstruction, we need to understand that foundation from reconstruction, or even if you're doing cosmetic, you have to understand that foundation and function. So look, we blink 1,000 times a day. The eyelids are dynamic. Every time you blink, it's propagating the tear across the eyeball, and the tear goes from your lacrimal gland all the way to the tear ducts. It's lubricating the eyeball, protecting that clearing your vision. So the eyelids play a very important role in that function. Now, I'm going to start from deep and then we'll come back out, but everyone in this room is a surgeon who's watching this. But just a review of some key components is that you have your bones around here, the zygoma, the maxilla, you got your ethmoid bones and the frontal bone. And the key position is that there is a difference between the position of this area, which is the medial attachment, and the lateral attachment, and that's important. The second thing that you need to be aware of is that the position of the eyeball in relationship to the bone over here, which is key. And by that, I mean the vectors of the eyes. So I'll be coming back to this concept, and most of you know this. If you don't know this, that there is a positive vector, neutral vector, and a negative vector. And by that, I mean it's the position of the eyeball in relationship to the cheekbone, right? To the cheeks here. So if someone has a positive vector, the eye is more inset and the cheek is out. Neutral is at the same line, and negative is back. So one of the things that's important is that the more positive vector someone is, the more youthful they look. And I will show that to you in some future slides. The second thing is, as we get older, there's a tendency to go from wherever you start, whether it's a neutral vector or a positive vector, towards a negative vector. So with aging, we all develop this negative vector component. So that's important to remember. So youthful is more positive vector. So as I mentioned before, the eyelids are this bilamellar structure that help protect the eyeball, protect vision. And the bilamellar structure, there's the anterior lamella, which includes the skin and the orbicularis oculi muscle, and the posterior lamella, which is the tarsus and the conjunctiva. And the proper function of the conjunctiva, it's a mucosal surface, and it is to protect the eye. But without this layer, the eye will not survive. So you need to consider it. You need to understand that how important it is when you're doing surgery around this area, and be very respectful of it. Now, if we're looking from the outside, the skin on the eyelid is one of the thinnest in the body. It's about 0.5 millimeter thick. And as we get older, it gets thinner. Another thing that's very unique about the skin in this area is that it doesn't have any sub-Q fat. So that's important when you're addressing concerns with the skin, which is probably one of the most common things you will see in your practice. How do we address it? Because it doesn't have any sub-Q fat. Now, the orbicularis oculi is a circumferential muscle. As I mentioned, it's involved in blinking, but more importantly, the eyelid closure component of blinking. It's innervated by the 7th cranial nerve, and it has 3 components. One is the orbital component, one is the palpebral component, and one is the tarsal component. So those 3 components are really important, especially when we're talking about cosmetic eyelid surgery, and we will discuss that. Another thing to note about the orbicularis is that as we get older, it does stretch, because it's constantly moving, it's constantly contracting, but it does get stretched because we're, rubbing our eyes, washing our face, putting makeup on, removing makeup, so it does affect it. Now, deep to the orbicularis is the septum, is the orbital septum. And as you know, it plays an important role because it really actually holds all the fat pad, all the orbital structures together, and it is somewhat an impermeable membrane. as you know, there is a, when somebody gets an orbital cellulitis, is very different than a preseptal or cellulitis, because of orbital cellulitis, that means the bacteria has already gotten into the orbit and it's a much more dangerous condition. So that impermeability plays a role. However, the thing with the septum is that it's the weakest close to the medial aspect of the eyelid. So as initially, that's why we get fat herniation medially, is because it's the weakest in this area. And it attaches to the arcus marginalis, and it forms a connective tissue, which we call the orbital malar ligament or orbital retaining ligament. Another thing I want you to, that's hiding in this area, is this inferior oblique that is attaching to the posterior part of this orbital rim, and you'll be seeing it, and you should be looking for it every time you're doing lower eyelid surgery. Here's a view of the inferior oblique coming in from the internal aspect of the floor of the orbit, and then it crosses laterally. So it's an important muscle, obviously, and you don't want to be cutting this when you're doing surgery. Now, there is a tear trough ligament, and this is a paper by Chin-Ho Wang from with Brian Mendelssohn's group. They published the anatomy of it, and this is something that you will see, and it's the medial aspect of the orbital retaining ligament. Now, we'll be using these terms interchangeably, but understand that there is this connective tissue that comes in all the way, and medially they were able to demonstrate that it actually separates the palpebral portion of the orbicularis and the orbital part of the orbicularis oculi. And this is a fresh cadaver dissection. They peeled off the skin, and as you see, you can see that tear trough ligament bifurcating the muscle. In fact, one thing that's really nice about this is that immediately underneath the skin, you see the orbicularis oculi, but underneath the skin on this region, you're seeing the sub-Q fat that I was talking about. So that's important to understand again. Now, this is a deeper section of it, showing it, separating the muscle, and it's deep to the muscle. So that's really important to kind of understand that relationship. Now, imagine if we are looking at the arcus marginalis, where we talked about the tear trough ligament. I want you to, in a 3D fashion, just extend something. And this is actually the orbital, this is the malar septum, that as you move anteriorly, the malar septum separates the deep and superficial SUF, and I will show you this in some other photos, but it will attach to the skin in a zygomatico-cutaneous ligament. So that's important. Another thing that's very important about the malar septum is that it is also impermeable. So that's really key. And we see this anatomically, this impermeable barrier, in patients who get a black eye, or they have malar edema from fillers or from festooning, that the inferior portion is where the fluid settles, because it can't go more deeper to that. So that's important to understand, because we're going to be operating around the eyelids. So the lymphatics in this area is important. One thing about the lymphatics in this area is that it's very unique than the rest of the body, in that there is this watershed area that the lymphatics actually don't have any valves. So again, another Brian Mendelssohn paper that looked into the deeper and superficial lymphatics. Look, this photo is from 100 years ago, and we've all seen it. We know about the superficial lymphatics that we have in the face, and we're all taught that, there's this lateral lymphatic, there's this medial lymphatic, but the deeper lymphatics play an important role. And in fact, they were able to map this out and look at it with an indocyan in green to kind of plan it out. But I was talking about this area, which is the watershed area. And the watershed area is really important because it doesn't have any valve. The lymphatics in that area don't have valves. And this is a typical lymphatic channel with the valves, which allow propagation of fluid in a unidirectional fashion. So this is the lateral, again, medial lymphatics. So let's get to the canthi, which is really important because it's the tensile strength of the eyelid. And we have two of them, the medial and the lateral canthi. Another thing that I want you to note is the canthal tilt, which is the position of the relationship of the lateral canthus compared to the medial canthi. So, and the way that works is that you have a positive canthal tilt if it's going towards this direction, and negative goes towards the down direction. And then when we dig in a little bit deeper, the attachments of the medial, it has a posterior and an anterior attachment, which they both hug the lacrimal sac here. And then these are the lower eyelid. This is your tarsus, the lateral canthus. These are the lower eyelid retractors. And if you're doing a transconj blepharoplasty, you are going to open and release these, which is actually important because, as I will talk to you later, it's one of the ways you prevent any kind of retraction from happening in that fashion. Again, we're digging a little deeper in that fashion. We're seeing the orbital fat pads, and the relationship between the inferior oblique is important because it does separate the nasal fat pads from the central fat pads. And then there is the arcus expansion, which is an extension of the Lockwood ligament, attaches to the arcus here. And I will show you in some of the videos during surgery, you will be certainly seeing this. A little bit more about the canthal tilt. As I mentioned before, we have positive, neutral, and negative. Generally speaking, a positive canthal tilt is thought of as vibrant, youthful, and a negative canthal tilt is associated with someone who's older and looking tired and not happy. But that's kind of nonsense in my opinion, because you have three beautiful people here in this photo. They're all youthful and all beautiful, and they have all different types of canthal tilt. So that doesn't really define it. And when we look at beauty, our standards should be a little bit modified in terms of we have to look at the person as a whole and see how it relates to the rest of the face before wanting to extremely change people's faces. So a positive canthal tilt, having a fierce looking eyes. In fact, a lot of times when women or people are putting makeup on, they're trying to create a positive canthal tilt, as you see in this video. So that's something that a lot of makeup artists do as a way to create that openness to the eye. But here's, Zendaya, who is a beautiful, has a neutral canthal tilt, and she's youthful and beautiful. Now, some celebrities with a negative canthal tilt, the most famous, Rocky Balboa, Sylvester Stallone, his eyes are just classic, the way the lateral canthus sits compared to the medial canthus. Well, but more important than someone more attractive and beautiful, Marilyn Monroe, she's known for a negative canthal tilt, and she's, as you know, one of the most beautiful people in the world. So now that we kind of reviewed some of the anatomy, I want to talk about important, eyelid support structures. And since we're doing eyelid surgery, we need to understand these things. So the eyelid has two components. One is the support structure, one is the bolster support, and one is a tensile support. And the tensile support of the eyelid is the tarsoligamentous sling, which, as we talked about, includes the medial canthus, including the tarsus and the lateral canthus. So the medial all the way to the lateral. And the second thing is the orbicularis tone. The orbicularis oculi, as you know, has this baseline tone that pulls the lower eyelids up. And this is evident in patients that get facial paralysis. As you see, patients with facial paralysis, the eyelid immediately drops down, and the loss of that tone leads to malposition of the lower eyelid in those instances. So the tone of the orbicularis oculi is very important as a support structure for the lower eyelid. The bolster support of the lower eyelid includes malar soft tissue, inferior orbital rim, lower eyelid fat pads. As you can imagine, the lower eyelid fat pads are actually holding the eyelid in position, and they bolster the lower eyelid up. But also, as I mentioned, the orbital rim plays a role. And as I said, as we get older, there's this tendency for a negative vector component, and the support structures of the eyelids go down. And if you ever look at someone who's very young, they have good support structure, tight positive vector eyes, and as they get older, that the eyelids retract back and drop down. So the bolster support is important. Why do I say this? Obviously, because we're going to talk about lower eyelid blepharoplasty, and part of that involves how do we deal with this fat that's part of the lower eyelids that gives the issue. And you have to understand that the lower eyelid fat pads are their position is dynamic, and it depends on the gaze. And as you will see in some of our videos, when a patient is looking down, the inferior rectus pulls the eyeball down, and that pulls the fat pad inward. And if you're very aggressive with your fat excision, then you're going to have retraction and get in trouble. So that's really important, that the relationship of the fat with the muscles and the orbit, it all is in harmony, and you have to be respectful of that. This is an example of some patient that I saw years ago for a revisional case, and they had significantly hollowed her out, and the bolster support of the eyelid is gone in that position. Okay, so before talking about our surgical approach or anything, getting deeper, I want to define what it is to be youthful. And we actually asked a question on our Instagram, and these are the gamuts of answers we got. Some people said firm, and it makes sense when you look at somebody who's youthful. The tissue is firm and tight. Another thing which stands out is this lack of shadows. And that's important to understand, because as I will explain in a bit, that's important. Another thing is positive vector, as I described, that a full cheek and a full face is a positive vector, and that relationship is youthful. And as we talked earlier, positive canthal tilt, although not on everyone, but generally speaking, is associated with more of a youthful appearance. Look at some examples. Every Vogue cover that you look at, this is a patient who has, there are no shadow effects that you see, very tight, firm skin, lack of any kind of wrinkles, lack of any shadowing, and is positive vector. The cheeks are actually sitting ahead of the eyeball. Zendaya, as we talked about, has a neutral canthal tilt, but also very minimal shadowing between the lower eyelid and the cheek junction. So lack of any wrinkles. So and it is youthful. Same with Gigi. Again, positive vector, although you do see her smiling, and that's natural to have that line, but again, positive, lack of shadows. Here's a model, male model, lack of shadow effects, tight, firm, skin texture is good. Kiana, in his younger age, you see again a lot of the shadow effects. He doesn't have skin texture is good. He has a positive canthal tilt, but the shadowing is minimal. Madonna in her younger age, again, tight, lack of shadowing. One thing, obviously, with Madonna, she's had multiple surgeries in the past, and as you see that, you know, there is an issue with overfilling, and overfilling is not certainly, when we talk about all of these procedures that we're talking about, we want to maintain the idea that less is more always. So what happens to us as we age? So obviously we've seen this model that as we get older, we lose volume. And that's been the narrative by most of the filler companies out there. But it's not the whole story, as we all agree here. You know, as surgeons, you understand we also lose collagen, elastin, bone, as we talked about. There's this loosening of the fibroseptal network that holds the tissue tight together. And then as we get older, there's this shrinking of the skull. So there's this stretched tissue that's on top of a shrinking skull. So we can't just fill the face to youth. It's important to understand all these other aspects. In fact, nowhere in the body show the signs of aging as easily and as apparent as the eyelids, because as we talked about, the skin is the thinnest in the body, and we're blinking 1,000 times per day. And there's this continuous soft mechanical trauma, whether it's through wearing makeup or, you know, putting makeup, washing your face, rubbing your eyes constantly. So you're moving this tissue continuously in a back and forth fashion. And as you know, this is a famous picture of a granddaughter on the left and a grandma on the right. As you see, they have, in fact, similar color and shape eyes. However, the grandma has this, the first thing you notice is that there's this depletion of volume, holistic depletion of volume from the subbrow fat to even all the way to the lateral hollow and inferior hollows. And there's this fat herniation, and there's this stretching of the skin that happens as we age here because of this soft mechanical trauma and continuous loss of collagen and elastin. So these are things that we have to look for when we're looking at lower eyelid and or periocular rejuvenation. And how do we address these? How do we address each aspect of it? And every individual, as you know, is unique, and we need to understand those aspects to create a natural, youthful result, which is important, which is basically what all our patients want. But as I was mentioning before, a couple of things happen. The bones do change. The skull, as I mentioned, shrinks over time, and the orbits actually get bigger. And as we get older, the orbits do get wider and bigger. And as I also mentioned before, there's this rotational change towards a negative vector eye, where the frontal bone comes forward and the maxilla retracts backward. And this continuous slow changing changes some of the external perceptions of things that happen. Why is this picture important? Because if we're talking about rejuvenation on the lower eyelids and you're just focused on the lower eyelid anatomy, then you're not really in the fat herniation and the eye bag, as we will talk about, then you're missing half of the other picture, which is the midface. And in my opinion, this unit needs to be thought about as one unit. The lower eyelids and the midface has to be thought of surgically as one unit. So I like to think about the lower eyelid and periocular region as a series of hills and valleys. So the first hill we see is the orbicularis roll. This is the pretarsal orbicularis. That's the first hill. And then the first valley is the lower eyelid crease. So the lower eyelid crease is analogous to the upper eyelid crease. And the next hill is the fat herniation. And this is where a lot of patients come to you and say, look, I have eye bags. And then inferior to that is the tear troughs. And then as we get older, we develop this lateral hollow. And the next thing above it is the malar region. And as we talked about, it's susceptible to fluid retention because of the impermeability of the malar septum and the lymphatic anatomy in that area. And inferior to that is the zygomatic hollow, which is the attachment of the zygomatico-cutaneous ligament. So it's important to understand that. And as we get older, we get more of these lines of distractions. So this is the queen, obviously, when she was younger, as you see, tight, firm. We see an upper eyelid crease, actually, but things have deflated. The orbicularis has stretched. There is volume loss, certainly. And when she's smiling, you get this significant amount of bunching that happens in that area. And there is this collapse, general collapse of just the periocular structures, even from the brow to the subbrow fat to the skin, that everything's just collapsing and the eyes get smaller. So as you see, there is a positive tilt here, although the tilt is still positive, but it's hiding with all of this bunching that happens, which a lot of our patients complain about. Another famous, obviously, Bill Clinton, as you see, youthful, tight, lack of any shadows or lines. As he's getting older, he's starting to lose the volume that happens. He's got the tear trough form in his 40s. And the orbicularis lines, because of continuous, obviously, movement, we get the crow's feet. And there is, again, the eyelids are starting to collapse into each other. And the orbicularis, as he's getting older, in his 60s, orbicularis roll is showing more even. And the skin is getting thinner. So those are some of the changes that are happening. One of my favorite actors, Al Pacino, as you see that he's showing a significant amount of signs of aging. Not only there is volume loss and there are skin changes and the muscle extensions, but you can actually see the hollowness in the temple, around even the midface, and there's a general descent of the tissue. And obviously, someone who, and by the way, you're seeing some of the festooning, which is the malar mound region in this area that's present. As we get older, we need to obviously think about the rest of the face that's falling down and how do we address those issues. But the changes around the periocular region are consistent with everything else we see. Here's actually an app that one of my social media people wanted to say, this is me today in center, and this is the app, a filter that gave what I would have looked like in my 20s and what I would look like in my 80s. And you see the lines of this distraction, the hollowness, the redundancy in the orbicularis, the deepening of the orbicularis. All these things present more as we get older. So those are important. So youthful is tight, everything, and things loosen up as we get older. Okay, so I want to now walk you through the patient journey and talk about from the time the patient comes to see you to, before you take him to the OR. What is this consultation about? Few things. One thing is actually we have a course called the 5-Star Patient Experience. I highly recommend you taking it, your team taking it. I was so humbled. Actually, one of my colleagues from Argentina, he actually went and translated that entire talk, which is a 4-hour talk. We have people from Disney, from multiple different hospitality businesses giving lectures on how you give a 5-star patient experience. And the consultation is actually really important. So I have a talk on that you can watch, but just briefly to tell you that the consultation is probably one of the most important steps in this journey. We actually, in our practice, I'm very blessed. I have a 1-year wait list for new patients to see me. But in order to make things efficient, we have a dedicated consultation day. So 1 day a week, the entire team is ready for that consultation. And that means the MAs are ready. They know exactly what to do. They know how, when the patient comes in, after they check in, they take them and take their photos, standardized photos. And then the patient goes into a consultation room, and the video of the patient is, the picture of the patient is in our big TV that's shown to the patient. And I use that picture as a tool for me to kind of understand what is this patient's issue and why is this patient here. And there is only one goal for the consultation, and its goal is proper patient selection. And I think if you are a practice that is doing a consultation in 10 minutes and you don't have enough time to talk to your patients, or you delegate that care to someone else, and you are going to miss a lot of important key points and clues about the patient you're about to operate. So it's important to have plenty of time. In our practice, we set aside 45 minutes for new patients to see me. So I go through their entire history and everything. So it's important to, when a patient first comes in, you have all that teed up. So what is the reason most patients come and see you for a cosmetic eye concern? Most patients' chief complaint, they talk about, I'm looking tired. I'm tired of people telling me that I look tired. Or a new one these days, that I don't like how I look on photos when I'm taking selfies or at different angles. And, or the common old ones, which are the eye bags, or my eyes are puffy and hollow, or, dark circles. There's a lot of crepey skin concerns, and, I have excess skin. So it's important. And in our practice, actually, I sit down and, write down everything in detail. But these are typical cases. We see a patient coming in complaining, in her 40s, complaining of looking tired, or someone even in their 20s who is very youthful still, but complaining of looking tired because of all the things I mentioned about youth that kind of goes away. This is how she describes it.
Every time I get unhappy with my eyes and I look in the mirror, I just do this, and that's exactly how I want them to look.
So, what she's doing is actually covering the lines of distraction we talked about. And so that's important, because she wants to have unified position and transition between the lower eyelid and mid face. So she's covering it, and it's a common thing. It's another beautiful patient with actually beautiful color eyes, who has, complains of looking tired and looking older, and everyone, she's in her 20s, yet, people tell her she looks tired all the time. Or someone in her 50s who's your most common patient you see, or someone older who mainly complains, when I'm smiling I look tired and I look, my skin bunches up. Or people who've had other, procedures done by other surgeons, and even, someone in their 30s who want that perfection on the lower eyelids. And we'll talk about festoons, which is another thing that you will be seeing, and how we manage this. So your role during the consultation is to listen. And I am all ear. When I walk in, I actually greet the patient with their first name and introduce myself. And I tell them what's going to happen. I say, look, first of all, I'm so honored that you're here to see me. I'm really excited that I get to meet you. And I'm going to first come up with a wish list for you. And it is the reason you're here. So this is something subjective. It's something that's bothering you. And I write down everything verbatim. I say, okay, you're bothered by A, B, C. And if I don't understand it, I repeat it. And as I mentioned, we have their picture up and on the big screen. So we go there together and look at it and say, okay, this is what bothers you. This is not what's going on. And all the time we have the patients bring their old photos when they're younger, because I want to see some of the anatomical changes that have happened, and what is it that they liked from when they were more youthful, and what are the changes they want to have. Now, this is important so that's why a 10-minute consult won't let you dab into that. It's important to have more time with them, because the goal again is proper patient selection. So you want to listen for red signs. These are red signs or red flags. And if a patient has unrealistic expectation, it's really important. And we do a lot of revisional surgery, and I find it that most of the time, the reason the patient is unhappy is because the patient was thinking of this type of expectation, and the doctor didn't listen and was offering at this level of, result, and they didn't match. And it's that mismatch that leads to unhappy patient. I mean, it's as different as like wanting patient is expecting to go to New York, and you're gonna just send them to Las Vegas from LA. So you're gonna miss the whole process, and it's important to understand that. So if a patient is talking bad about previous doctors, that's a red sign. I listen for that. Usually if they bring gold pictures of other ethnicities, you have somebody who's, Caucasian, bring in some patient of a picture of an Asian eyes and wanting to look like them, or vice versa, which is not possible. If they've had multiple previous surgeries, and look for signs of body dysmorphia. And if you practice long enough, you will have a patient that's going to have body dysmorphia. And it's really, really important to identify these people. Usually these patients have had multiple surgeries before, and they're not happy, and they're unhappy with everything. Also look for patients who are really rude to the staff. Your staff gets a different perception of what's going on. In our practice, I turn away 30% of patients, and I have to actually do it in a nice way. But this discussion can take for a long time, but I just want to bring it, and I'm sure you guys have things to teach me, but it's important to look out for that issue, especially if you're just starting your practice. So let's talk about causes of dark circles. And there are anatomical changes that happen, and then there are which are eye bags, or hollows, and then there are most of the time it's a combination of both. And sometimes the skin is thin. I will talk about certainly allergic reactions can cause that. there are iatrogenic causes of dark circles, which we will talk about, and then racial melanosis and venous congestion. So eye bags, I mean, this beautiful patient obviously has, it's very clear that she has eye bags. And when somebody comes in with eye bags, I usually also try to decipher if they have any fluid retention as a component or an edema as a component. And I think it's important to distinguish between them. And here's a little video about this.
This beautiful patient complains of swelling, puffiness on her lower eyelids and upper eyelids. There are a couple of things that I want to talk about that are special about this area. So when we look at her lower eyelids, I noticed that there is edema, and this is swelling that extends above this ligament. So this is called the zygomatic hollow, which is an extension of the malar septum. It extends from the orbital malar ligament all the way through the zygomatic cutaneous ligament all the way here, and it separates the deep and superficial sousp. Now, the malar septum is actually an impermeable membrane, which means fluid usually can't go through it in here, so the fluid is always above it. So we see it actually on characteristically on areas where we talk about malar edema, which we look at over the malar region, the zygoma, there's swelling. Now, if you note here, there is swelling that extends into the orbit here. So this is actually edema that extends above the malar septum, over the malar region, and into the orbit. So when she looks up, we see a little bit of fat herniation, but look down for me. And when she looks down, I still see the swelling in this area, and this is swelling. And she actually reports that it gets a lot better based on what she eats.
So it's important to distinguish that, because no lower eyelid blepharoplasty will address the swelling. So usually I have a great grading system that we say, okay, 1 to 10, tell me on a good day what's a lower puffiness on the lower eyelid versus a bad day, and I try to get an assessment. I also at this time want to know if they've had any fillers, because as we will talk about, fillers block the lymphatics in this area and contribute to that swelling. So that's important. But not to say that there's no treatment for swelling. Obviously, lifestyle modification plays a role. Not sleeping on your face, cutting down on salts, preservatives, jade rollers, sleeping on your back. All of these things can help with that. And sometimes if there is an allergic component to that, the lymphedema, then we address the allergic issues and then prepare the patient for surgery to have better outcome. And this is something we routinely do before just jumping into surgery. So there's a patient who's got mainly structural hollow, but she also has a little bit of fat herniation. And here's just remember this: if you were to do a lower lid blepharoplasty traditional way and just remove a bunch of fat, you're going to contribute to her hollowness. And if you were to do a repositioning, it's not sufficient to address all the hollow that we see. And I'll talk about a surgical approach for this patient. You'll see a video of her. But another case, this patient has a combination of venous congestion, which is very common, with some periocular volume loss, including the temples, the zygoma, and the lower eyelids, and some fat herniation. So that combination is something that you see a lot. And this is a patient, again, with thin skin, and with, as I mentioned, sometimes the skin is very thin, and you can see the orbicularis oculi underneath it. And that's one of the causes that contributes. Now, this is a interesting case, and it's interesting because it's so common. It's a condition I call CLIF, which is chronic low-grade inflammatory induced periocular hyperpigmentation. So I know it's a lot of words, but let's back up a little bit. Think about PIH. What happens with PIH is that you have this inflammatory response that leads to hyperpigmentation. Now, I have probably maybe hundreds of these patients in our practice that we see, that when I see them, I know exactly what their story is. Usually their story, and this is this patient's story, from a young age, they've had chronic allergies, whether it's seasonal allergies or a little bit of eczema, or they're constantly rubbing their eyes because they're sensitive to everything that touches them, all kinds of lotions, potions, perfumes, shampoos, everything they're allergic to. This patient is actually very young, and because of this chronic inflammatory response, she's got this hyperpigmentation that extends all the way from the upper eyelids to the lower eyelids. And although she's in her 30s, early 30s, you're seeing some of these changes that are affecting things in a deeper level. So it's important to identify this and treat the underlying issue before you jump into surgery. One thing I will tell you is that we are finding that these patients, once you control their allergies, you can improve some of the hyperpigmentation. But another thing that can happen is that nanofat plays a major role on these cases. And it's something that I'm so excited. I will obviously talk to you more about it. It's something to keep in mind in terms of treatment for these patients. So this is another patient with severe, thin skin. You have venous congestion. You can actually see this congested. And a lot of times internally, when I'm doing these surgeries, as I'm doing it, I coagulate a lot of the venous pooling that I see behind the orbicularis. There's obviously periocular volume loss on this patient, around the temples, around the midface, around the zygoma. Again, lower lid blepharoplasty traditionally would make this patient look worse. Repositioning is not sufficient to answer her changes and the aging changes. There's also racial melanosis, which is something that is typically seen in Middle Eastern or patients of Indian descent, Southeast Asians, and the treatment for that is very difficult to treat. But I also think nanofat will play a role in addressing this. Now, one thing that I was mentioning, iatrogenic, and this is something that is commonly seen, and it's this people that are using Latisse or eyelash growth serums. The foundation of these drops is prostaglandin analogs. They're used commonly initially in glaucoma drops, and they noticed that the most popular of them is latanoprost, or known Zalatan. And they noticed that these patients were actually having their eyelashes grow. So then the patent was given to Allergan, and Latisse obviously owns the patent for that. And then so we had this period where everyone was using Latisse. Now everyone was using it. And then fast forward a little bit until this case series came. And this is actually so important for you to understand. There's a condition called prostaglandin-associated orbitopathy. This is a gentleman with a 4-year history of using Zalatan, just 4 years, and in the left eye. And look what's happening here. You have significant fat atrophy. He didn't have glaucoma on the right side. He wasn't using it. In fact, the group that looked at this, initially, they did a large series of patients that they looked at, and they said, okay, well, look, this is a side effect of Zalatan, and maybe we can use prostaglandin analogs for treatment of eye bags. And so they filed for a patent, and they were given the patent, and they turned around and sold the patent to Allergan, who was very excited to just buy it from them. And then they realized that the problem with it was so deep, and they were making so much money from Latisse, so they shelved the whole thing. But this is a serious problem that anytime you see someone with superior sulcus hollow and changes in pigmentation and irritation and discoloration that happens with these drops, it's important. I mean, the most common issue with it is hyperpigmentation around that area, but this is something to be aware of. This is a patient that I saw. This is her on the top left in 2018. Before I saw her, she started using, she had already actually used Latisse, but you see the superior hollow wasn't that much initially, but it got worse. And so she came to me complaining of, you know, in a matter of 2-3 years, just aging rapidly. So we actually, you know, I told her, are you using eyelash, you know, prostaglandin? Yes, I am. How many years? Like 6-7 years by then. And then we ended up doing surgery on her, the TriFecta. But it's something that, you know, you just have to be aware of and look for. Okay, so first you identify the problem, and then you take the patient for an exam. I think anytime you do an exam, you could check vision, because if you're operating out the eye, you may be dealing with someone who's already blind or has poor vision, or if you're just taking them into OR and not checking those things. And, you know, I'll have a little video on things we look for. I look for the snap test, blink dynamic, look, you know, for ptosis, brow ptosis, brow position, lower eyelid anatomy. I'm looking for the volume loss, you know, documented zygomatic hollow, lateral hollow, any malar edema. For every exam, we want to document vision, and it's one eye at a time. And so go ahead and cover your left eye. So we use just a Snell reading chart and document the best correction, one eye at a time. Next, we want to check pupillary reflex and have the patient look far and look at the reflex and document. So next, you want to check ductions, and there's a movement of the eyeball in different positions. The patient's head is not moving, just the eye is moving. So after that, we want to document position of the eyebrows, position of amount of excess skin on the upper and lower eyelids, amount of volume loss around the temples, the lower eyelid cheek junction, and look up for me, and look down, and look straight. So this allows you to get a good sense of things. You'll also look for snap tests, so where we pull down on the eyelid and see if it snaps back in position. Normally it should just snap back. Then we ask for facial expressions, so frown for me. Oh, you have Botox.
Yeah, that's what I said.
So with the brows raised and down, and, you know, big smile. And so we want to document it. Few things about patient selection. Obviously, that we can talk about this for a long time, but for the sake of the, you know, our time, you got to look for active inflammatory diseases. And even if they have seasonal allergies or things like that, I want to manage these things before I take them to the OR. I look for thyroid eye disease. And as you know, that is an inflammatory issue that needs to be worked up. And we look for, you know, if someone has proptosis that showed up in the past, you know, 2-3 years, or has significant changes from the time that you look at their previous. That's why it's important to look at previous pictures to the time you see them. You know, you also want to distinguish, as we said, between puffy eyes versus eye bags, and how much, because expectations will change significantly. And the reason I'm saying this part is because when I'm operating on someone, I want to make sure that we're on the same page. What am I about to do for you? What can you expect? Am I going to take you to New York, or we're going to leave you in Las Vegas and you want to go to New York? I can't do that for you. So we're not going to take you on this journey. So it's really important for them to understand. So a lot of times when they have a lot of fluid retention, I say, look, you can expect 60%, 70% improvement because of the surgery, but there, you know, I can't address these other things unless you become part of the team. We all know about smokers. Obviously, we want them to stop a week before and hopefully forever. Another thing that we look for, previous fillers out. There is not going to be a patient in your practice, I mean, we see this on a daily basis, that hasn't tried filler somewhere around the mid-face and tear troughs. And I'm not just talking about the tear troughs. I'm talking about mid-face as well, as I will explain to you in a bit. It's really important because you want the fillers gone. Ozempic is another issue that's rising in our community. I don't know about the rest of the world, but the problem with it is that it delays gastric emptying, and if you're operating on these patients, you want them off at least 2 to 3 weeks prior to surgery because of risk of aspiration. All right, so we are going to talk about now what everyone's here for, which is the lower eyelid, trifecta. How do we approach it? Before I get into the technical things, I want to just tell you a little bit about the evolution of this technique. So the, lower eyelid surgery actually goes back to, there are documents 1,000 years ago from Abu Sina, but this was something I found. It's a 1907 publication by a plastic surgeon named Charles Miller. He talks about the corrections of facial imperfections. This article is actually available through open source in Google books. So it's interesting. They have 2 pages on it. And the only thing they talk about lower eyelid blepharoplasty is this picture and this subciliary incision with the removal of a little bit of skin for what I'm assuming is that excess skin being an issue. So, and treatment of wrinkles in that area. So fast forward from that time, it was only obvious that a subciliary approach to an eye bag was going to be the first approach because it's the most logical approach. I mean, you're going from an external incision and going to the orbicularis. You have to open up the septum and you have to get to the fat pads and remove them. And I know some of you perhaps today still do this approach to lower eyelid blepharoplasty, but the main issue, and in fact, this was a way I was taught when I was back at Bascom Palmer when I was in 2002 with David C, and this is how he did all his lower eyelid blepharoplasties. So the problem with the subciliary incision is that you have to open up the orbicularis. And as I mentioned before, the orbicularis plays a very important role in the tensile strength of it. And then the other issue is that you have to go through multiple layers to get to where you want to be. And there's an easier way, obviously, to do that. So this is an example of a patient who actually was operated on in Beverly Hills by a plastic surgeon who did a subciliary approach and was, the surgery was too long, did a 10-hour surgery, did the rest of the face. And unfortunately, the patient developed multiple issues, including severe eyelid retraction. So whenever you're disrupting the anterior lamella in this fashion, you're putting yourself at risk for causing not only eyelid retraction, but canthal dystopia. And I think this approach is just, there is no need to do this. And the transconj approach is a much safer, better option. By the way, I will mention how we treated this patient when we get to the complications portion. But, the transconj approach was first described by Bourget in 1924, who's a French plastic surgeon. And he described a case where he made an incision through the lower eyelid internally, and he removed a little bit of fat, and he went on and closed the lower eyelid. And the problem with all of these things is that if you are removing fat, then you are going to lead to severe hollowing, especially as we described that periocular aging is not just a fat herniation issue, and it's not just a volume around the tear trough issue, but rather a holistic volume loss around the face. So fast forward to 1981, Loeb, he described a subciliary approach to a fat repositioning technique, and you know, where they sutured either internally or externally the fat pads to cover up some of the volume loss, and using a sliding technique. And then later on, Goldberg in 98 described a transconj approach to this technique, which is widely used, by the way, by many of my colleagues. And in fact, I used to do this routinely. Now, the question becomes when and why do I ever do a repositioning? And my answer to that is yes, I will show you a case that I do repositioning, but I want you to think of this way. First of all, as we described, fat repositioning by itself is not sufficient to address the perifacial temple zygoma mid-face volume loss that is seen. And this is not an aging issue with this patient, for example, who's in her 20s. Again, beautiful eyes, but if you're just doing a lower eyelid fat reposition, you're not addressing it. And in someone like this, I would also want to address the skin quality. I want to address the skin changes. And as you will see, fat grafting, especially nano fat, as I will describe, is key feature of this procedure and how important it will make a significant impact in your outcome. So this is a patient, as I was talking about, lines of distraction, similar eyes. She's a famous Israeli model. And when you see her, the lines of transitions are not there. However, we see it on this beautiful patient with the same shape eyes, same age group. And when we address it with the TriFecta technique, it significantly impacts the results. So volume loss with fat grafting becomes a bigger part of it. So what are the options? I mean, look, you can either do fat grafting, or you can put an implant. And the problem with implant, although I used to do a lot of implants, especially when I was doing, you know, a lot of recon cases, but the problem with it is just it's one place. I can't address some of the other areas that I want to address. I can't just put implants everywhere. And then the other issue with implants is that, as we mentioned, as we get older, the skull changes, the eye changes, the orbits change, soft tissue changes, and you're putting in static implant, which will impact these changes, especially around the tear trough. Now, some patients who have severe maxillary hypoplasia will benefit from an implant, and we do that sometimes. So the best next choice is fat grafting. So what is the TriFecta technique? Before we talk about the technique, I put this instruments, and I really think instruments are key. And you know, you have to have the right instrument when you're doing surgery. The key things you want for this are your, you know, retractors, which is the Ragnow and the Damar retractor. I also have a shoehorn retractor. I routinely do the surgery with a Colorado tip cautery, so you need to have that in place. You know, your forceps at 0.5, Westcott scissor, Castroviejos. So typical oculoplastic trays, nothing really fancy. And I will have a video on for the fat grafting component, what are the instruments you need. But the goal of the TriFecta is to create this harmonious transition between the cheeks and the eyelid junction. And how do we do that? So for the fat herniation, if, you know, I want you to think about it this way, that the more negative vector someone is, the more I want to decompress the eyeball back. So I can remove as much fat as I want, given the fact that I'm supporting, as I mentioned, the lower eyelid position. And if someone has a positive vector eyes, you don't need to remove that much fat. You perhaps can do a repositioning in that situation because they already have full cheeks, they already have full periocular volume. So it's not a one size fits all, and you have to look at every patient independently. Another thing that I will show you is something that I routinely do is this RF assisted orbicularis tightening, which I'll show you how we do that. And then obviously the canthal support structure needs to be looked at. So someone who's really old will need more of a canthal support compared to someone who's young who doesn't need it. And then last but not least, we revolumize the midface with fat, and then address the skin component either through different various means that I will talk about shortly. So this surgery is always done under anesthesia. And the reason I do this under anesthesia because I want the patient to be comfortable. And so they're intubated, it's a propofol drip. And they have an LMA and a propofol drip. And I limit the amount of lidocaine I inject because I don't want, especially around the mid-face area. So that's something that I will tell you. And you see that when the surgery is done, if you're putting too much tumescent in this area, if you're combining it with a fat grafting or something, that lidocaine will impact the result of surgery. So the surgery or approach is a transconj approach. Again, I dissect things in a blunt fashion with the cotton tip applicator. And then I release everything all the way to the orbital rim, medially all the way to the laterally. And then gentle pressure over the globe allows me to find how much fat needs to be removed. Again, this is something that's based on the patient. And then I tighten the septum internally. And then as needed, I address the canthus and do a pinch. And then I go ahead and at this point, once I do one side, I go and do the tumescent, inject the tumescent, and then come back and do the other contralateral side. And for the fat harvesting, I use a 2 millimeter cannula, and then I pour the fat over a Teflon to allow separation of some of the oils, and I'll talk about that. And then we inject the fat anywhere between 2 to 20 cc, depending on how much fat they need. And then the CO2 is the last thing we do. So this is a patient, again, young, in her 30s, who came to see me. Here we have a young, beautiful patient that, the plan is to do a lower lid blepharoplasty with fat transfer and canthal tightening. I'm marking the tear troughs here and laterally. This is the lateral hollow. These are my standard markings I look for it. Obviously not everyone has it. This is the zygomatic hollow. And we're going to revolumize this place with our own fat. So the midface comes anteriorly and the fat pads are going to disappear. So there will be a smooth transition. It's possible we may do a canthal tightening here, but I make that decision. Smile for me. So I usually put it right at the lateral canthal level and relax it. So that's a medial fat pad herniation and a lateral fat pad herniation. Again, zygomatic hollow. Close your eyes, open. Perfect. So one thing about that lateral incision, you don't want to go above the canthal attachment, so you have to be inferior to that. So let's look at the video of how we approach this. So this procedure is performed under general anesthesia for patient comfort. Corneal shields are placed after the patient is prepped and draped in a usual sterile fashion. Lidocaine 1% with 1 in 100,000 epi is infiltrated into the lower eyelids.
The surgery is carried out by making a transconjunctival incision using a Colorado tip cautery halfway between the inferior border of the tarsal plate and fornix. The incision is then extended towards the orbital rim. Now I extend this all the way depending on the amount of fat herniation, and the goal is to initially, in a blunt fashion, separate the fat pads from the fascia before I start the deep bulking and contouring. Now, I don't believe in excessive removal of the fat, as you know, that can have negative consequences such as significant amount of hollowness. So the goal is to reduce some of the fat pad and contour whatever is herniated. Most patients, as you know, have a medial herniation, so that's the initial focus. But again, everyone is anatomically unique, and we extend this laterally based on the patient's anatomy.
So as you noticed, I didn't remove anything until I released everything.
So this procedure is booked.
So once I'm done with the fat contouring and debulking, I proceed with tightening of the orbicularis fascial plane. And this is a very important step because it allows significant improvement in the contour of the lower eyelid and minimizing future fat herniation. The way I do this, I use the RF Colorado, and in a fractionated way, I deliver the heat to the postorbicularis fascial plane circumferentially, as you see on this video. So once I'm finished with the internal tightening, I flip the eyelid to make sure that everything snaps back in a tight position.
So think of the RF orbicularis tightening as a fractionated radio frequency delivery. I mean, RF, your Colorado is an RF device. It's one of the oldest ones. And, you know, I had this doctor from Spain actually who came and watched me. And then 2 months later, he called me. He said, I got this eyelid retraction. What should I do? And you have to be very careful. I'm not talking about burning the septum, and I don't recommend using any high power on this. And the reason you're doing this in a skipped fashion is because you're allowing the body to heal in a nice fashion, right? It's circumferentially tightening internally. Again, not too much heat in that area.
At this point, if there is any skin pinch that is needed to be removed, I proceed with doing that. Now on light skin individuals, I do a CO2 laser resurfacing. But if it's a skin pinch that's part of the lower eyelid blepharoplasty, this is the point that I will proceed with that. Now, once I'm done with the lower lid blepharoplasty, then I proceed with the fat transfer.
Okay, so what you just saw was actually a orbicularis suspension. Okay, I didn't do a skin pinch that goes all the way across. What I did was wanted to reinforce the orbicularis muscle so it's pulling the corner up in a nice fashion. And what also you should notice is that the incision that was made was inferior to the canthus, right? Right at the inferior border of the canthus. So that's important. So let's talk about fat transfer. You know, most people are concerned about fat grafting because they say it's unpredictable and it doesn't last too long. It leads to lumps and bumps. Overfilling is definitely a hard thing to correct. And weight gain and weight loss can be an issue. Certainly, these things can be concerning, but if you're using a right technique, which I will describe to you, chances of these things happening becomes significantly reduced. And then you're left with the advantage of the fat, right? So autologous fat has about 25 to 25% stem cells, and that's a big thing. It's very predictable. I mean, I have patients that I've done fat grafting on 12, 14 years ago, and they still look amazing. And there's this skin rejuvenation element that happens with fat grafting, and which you can't really achieve with anything else. Now, I've included in your handout a bunch of great articles, and this goes through the history of fat grafting. I mean, it's been around since initially it came about in 1893, and there was actually, of all things, there was this adherence scar around the orbit region on a patient who had osteomyelitis, and they put this fat graft there. But fast forward a little bit, it was used in different areas around the face and body and breast, and the problems they were having was that it was unpredictable, and it was leading to a lot of this oily cyst and fat necrosis, and it didn't last too long if they tried to do it in different ways. So in the 1950s, it was pretty much abandoned as a procedure. Now, fast forward in 1990s, and as you know, Sidney Coleman really did everyone a huge favor, because his techniques really changed the way we approach fat grafting. And by doing, harvesting and purifying the fat in a better way, the resorption rates were significantly reduced. And then fast forward to early 2000, so we're not talking about too long ago, about like 20 years ago, where Zuck and his colleagues, they discovered what we call today mesenchymal stem cells, and which are in my opinion, the magic of the fat. These are the stem cells that are part of it. And since then, there have been multiple different publications, and I've included a bunch of these for you. This is they talk about role of microfat grafting in facial contouring. So this is from Patrick Tonard's group. And if you guys are in Belgium ever, you get a chance to visit Patrick. He's an awesome guy, and he would love to have you guys. So you just need to reach out to him. So before we get into this, I want to just make sure everyone understands what is the difference between macrofat, microfat, and nanofat.
So basically, we are liposuctioning fat for injection, and the first aspirate that comes out we call microfat. So I really like to actually use the fat as is, and basically I take it and we inject it, re-inject the cells. What's great about it is that it has stem cells about 15%, and the fat cells, and which are great for volume augmentation. Now, if we take the fat, the microfat, and process it through a process of emulsification, we're left with the stem cells. That means we're getting rid of the fat cells, and what's left at the bottom is the stem cells, and that's called nanofat. So nanofat is great not for volume augmentation, but for skin texture, for collagen synthesis. So a lot of times you hear me say, okay, we're going to use nanofat in this procedure, and that's when I'm talking about the stem cells. And that's the difference between microfat and nanofat.
Okay, so that's the difference between microfat and nanofat. And what is macrofat? Now, macrofat is when you're using a large cannula, which is 3 millimeters, and you're harvesting fat. And the problem with macrofat and facial fat grafting is that it's too big, and it can lead to a lot of these lumps and bumps. And a lot of times I see on Instagram that a doctor's doing a liposuction on somebody, and then they use that same cannula and they're injecting that fat without really processing it into the face. So if you are injecting fat into the face, you should use a 2 millimeter cannula. And by the way, I have let Tulip know, and you can reach out to them and ask for the Kami Parsa set, and they will send you everything that I use, so you have access to it. But nano fat grafting, there's a lot of, this is actually one of the first papers that Patrick Turnard's group looked at, what happens when you're using a nano fat. And they actually looked at fluorescein microscopy, and this is the photo above is lipoaspirate from a macro fat, and this is a micro fat. As you see, you are seeing the fat cells show up, but once you emulsify it through the nanofat emulsification process, where I will explain to you, then you get rid of all of the fat cells. There's really nothing here. And when you look at them in a phase contrast microscopy, you see a lot of the stromal vascular fraction. 7 days later, you'll see cell culture that has stem cells in all three groups, especially in the nanofat group. So nanofat is used for treatment of sun damage, scars, dark circles, hair loss, and it's a big component of our practice. There's another paper that I've included for you. It talks about a technique, Sophie Menke's group, where they describe subdermal injection of the nanofat in this fashion, and they actually went and looked at it. So it really shows this is not some voodoo science. We're actually seeing before and after biopsies that show significant growth in collagen and neogenesis collagen and elastin synthesis, which is a big part of the aging process. And these are different slides that are used. So these are some of the instruments. Again, I have included them for you, but
hi everyone. So I'm going to talk to you today about the instruments needed for the microfat and nanofat injection. So as you see here, we have everything laid out, and this is a infiltration, tumescent infiltration cannula, and you can either use a 2 or size 3 cannula. This is a 2 that we use. If I'm doing only microfat transfer, then I go for using a 2 Mercedes triple set cannula. It's 1 millimeter, so this is a special design, 1 millimeter, and it's a 2 the size 2 gauge. And if I'm only doing nanofat, I use the Tonard's harvesting cannula. They have different sizes, so it's the SL 2.4 and the SL 2.1. You don't want to go with anything bigger than that. So this is great for just a nanofat if that's what you're doing. I also use the 0.9 tulip cannula. So this is the SL 19. Now you will need a blade holder for the 11 blade, and then you need something to suture and a forceps for that. If I'm doing nanofat injection, I like to use Dermasculpt's blunt 22 gauge. If I'm going for the tear trough, or 25 gauge. So those are the 2 I use for the injection, and you'll see a video on that. Now, for the nanofat, this is the tulip set, and as you know, so this is the input, the standard tulip set. You start out with the 2.4 emulsification, then you go down to the 1.4, and then finally 1.2. And you'll see that on a separate video, that how I actually use those things. I also, for the harvesting, I don't need anything fancy. I just use a 30 cc syringe, and that creates negative pressure for me to harvest the fat. Now for the injections, I typically use a 1 cc syringe, so that's key. And then you also need some sort of a 3 or 5 cc syringe for the lidocaine injection. And we do have a kidney basin to lay the telfa that we use. So this is the telfa. Again, I'll put information on how you get that. We lay that over, and then the fat goes over it, especially if I'm just doing microfat. So for the microneedling of the nanofat, we use the RR ratio. The good thing about it is that it creates a negative pressure as it punctures the subdermal tissue, and that negative pressure sucks the nanofat and injects it into the subdermal space. So this is one of our favorites.
Now here's a the tumescent.
So I'm going to talk about the tumescent that we use. First of all, because we're just taking out a little bit of fat, so it's not a major volume. I'm not doing a major liposuction. This is very focused liposuction. I don't need to have that much tumescent, and that makes it really safer in what we are doing. So for this purpose, typically you can either make your tumescent in a ratio of 1:3 or 1:4. So what do I mean by that? By that I mean your lidocaine to your normal saline, the ratio is either 1:3 or 1:4. Now, and I know some of my colleagues actually make it even 1:5, so that's also fine. But let's take that for as an example. So typically in our cases, I only need about, 60 cc's of saline, or sometimes double of the tumescent. So the way that works is, let's say 15, if I'm doing a 1:3, that's 15 cc of lidocaine 1% with 1 in 100,000 epi mixed with 45 cc of normal saline. Now this is bacteriostatic, it doesn't have to be bacteriostatic. Now, if the patient is awake, you can also add about 5 cc of 8.4% sodium bicarb. So that's all you really need, and I'll put some information on this on our documents that we'll share with you.
There's a lot of talk about, okay, what's the best way, and you talk to different doctors, and this is actually a great article that reviews the different techniques in terms of how do you harvest it, what's the best way to harvest, what do you do, how do you process it. And I can obviously, the harvesting part, there is really no good long-term studies that says, okay, you should not get it from the abdomen versus the flank versus the thighs. And in my opinion, where we usually get it from the abdomen or the flank, some studies say, okay, well, it's better to get it from the abdomen. Some have shown that it really doesn't make any difference. Some people are worried about is this going to be more susceptible to growth if you're getting it from the abdomen. I can tell you that I've been doing this since 2006 and we haven't had any issues, and we'll get to the complication part in terms of the growth of it, except one patient, and that was on a gentleman who gained 40 pounds. But so the typical locations include the abdomen, flank, thighs, now let's see.
Okay, so we've injected the tumescent already to this area, and I'm going to inject some lidocaine. I already injected some, so this is going to be our harvest point, using an 11 blade to first make a little incision. Bevel is up, and then I use a curved hemostat to go through here. And now this is a 2mm cannula. So I'm going to first release the tissue bluntly. I'm not suctioning anything. And this is a 20 cc syringe. Okay, then we create a little suction and harvest the fat.
So once the fat is harvested, then we just pour it over the top.
Okay, going for the flank region, releasing things bluntly here. And you got to make sure, understand that this is we're going after subcutaneous fat, so you don't want to go deep with this, right? So that zone is important. So I'm just releasing. And now I'm going to create the suction and hold it back. Now, Tulip makes a little lock here that you could put with your instruments. We have it, I just don't use it because I'm so used to just doing this without it. But if you want to, you can certainly buy that.
So, and that's it. And then you close with an absorbable, usually a 5-0 or something, plain suture. And, so what do we do with the processing? And that this is important. And there's a lot of debate about how to do this. And I will share with you the common ways people do it. And I've tried every one of these ways that I will mention. You can either centrifuge, and there's actually a Coleman method, which you spin for 3 minutes at 3,000 RPMs. And, or you can wash it, or you can let it sit and sediment, and that allows separation of the oil and everything, or you pour it over a telfa. Now we do have a centrifuge, but I use it if I'm doing a lot of fat, and someone who needs lots of nano fat and things like that. So most of the time, if it's just a small amount of fat being injected during surgery, I just pour it over telfa. And ultimately the biggest testament to anything is just the results. So I look at like Tonard, he doesn't centrifuge. I don't centrifuge often, but sometimes do. And I think it's much more the cannula that you use to harvest is really important. As I was mentioning, if we want to make sure you're not injecting any macro fat into the tissue, and separating the oils is important, but also the telfa allows it. And sometimes I feel if you're centrifuging, you're getting rid of a lot of the good stuff, which is part of the aspirate. So let's talk about, before I talk about injection techniques, I want to mention something which is really important. This is actually a 2019 article that looked at cases of blindness. They had about 190 cases they looked at, and 50%, so 47% of the cases were due to fat injection, right? So only 28% was because of HA fillers and other things. So that's a big number. And I want to make sure, and I dug into this actually, none of these cases were cannula related. And part of the reason that you have such a high number is because they were using needles to inject, nano fat or micro fat, and it's not the best option. So these are the areas that you will run into trouble, even if you're doing HA. So we're talking about the nose, the glabella, the forehead, and some in the nasolabial folds. But the red zone is around this area. So obviously you have to be careful with needle injection in this area, and using a cannula is not 100% safe either, but let's talk about it. So cannula versus a needle. So there is no doubt that when I'm injecting microfat, I'm using a 0.9 Coleman, which is a 19 gauge. So it's impossible to get this through an artery. Okay, so it's chances of an occlusive event with a cannula of this size, it's very, 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 very rare. Whereas a needle, you can get into an artery. Now, there is a difference between anterograde versus retrograde injection. So what does that mean? If you're injecting pushing forward, then you're at more risk versus going forward and then injecting retrograde. So that's really key. Retrograde injection is safer, in my opinion. Syringe size matters. And why does it matter? If you remember from your physics, force that's generated from a cylinder equals pressure times the area, and the area is calculated by pi r squared. So the bigger the diameter, the radius of the cylinder, the bigger force is going to be generated. So I'm assuming that the pressure is the same. If you're using a larger syringe, then you're going to have more force generated. So that's really important. So that's why you should just use a 1 cc syringe injected with a blunt cannula in a retrograde fashion, and chances of you having an occlusive event is going to be very, very minimal. So that's really key. I've seen again on social media that they're using the doctor who is a TikToker or whatever, they're using a 5 cc syringe and they're injecting it, anterograde. Please don't do that. So let's talk about the transfer.
So I typically harvest the fat either from the periumbilical, the flank region. We inject the normal tumescent, and once fat is harvested, we transfer it to a Teflon, and then as is, I don't spin the fat, and I transfer it into the microfat into 1 cc syringes. Now for injection, I use an 18 gauge to gain access for my pilot, and then use a Coleman cannula 0.9 to inject the fat. The goal of fat injection is to revolumize the cheek area and create more of a positive vector eyes. So my pilot is over the lateral zygoma, and fat is injected in a retrograde fashion. On a typical patient, anywhere between 2 to 6 cc's of fat is injected into each side. And I have two ports, one is the laterally and one inferiorly. Once I'm done with that, then we go ahead, perform a CO2 laser resurfacing if the patient needs it, or we place a steri-strip that stays in place for a week.
Okay, so basically the CO2 laser surfacing is afterward, and I will talk more about that. But if I'm not doing that, I put a steri-strip to reduce swelling. So let's go to the next. So this is that patient I initially showed you. This is her a month after surgery. This is a video of her a month after. Healing is relatively quick. So, most patients go back to work after, 7 to 10 days or so, depending on what we're doing. Key points about microfat transfer is that you should not inject lidocaine into the midface or tumescent into the midface, as I think that will distort the tissue and also affects fat survival. And I think nanofat obviously has to be done. If you're doing nanofat, you first do the CO2 and then you do the nanofat, microneedle it like I showed you. And then less is more. Don't over inject, especially when you're starting. As you will see, if you're doing too much, then you're gonna have some problems. So what do we do with skin? We talked about the options for it is either a pinch or a CO2 or a peel. These are things you can do. It's just a video of a pinch that I typically do. I use a brown forceps and then just remove a little bit of skin subciliarly and extend it out and cauterize as needed, and then use a 6-0 plane to run it through. So it's relatively simple. I don't believe in extensive dissection of the skin like some old school doctors do to separate it from the orbicularis. I find that kind of just too much, too crazy. There are things you can do that to address the skin. As I mentioned, it's the thinnest skin in the body. So separating it from the orbicularis is just not a good idea. You can have lots of issues and retraction problems with that. So that's that. And then as far as CO2, we use a DECA. I've included these settings that we use. The depth of it's a fractionated CO2. You use it in that mode. Their variables are the power, the dwell time, and the spacing between them. Typically speaking, you can, modify the density of the spacing. You can modify the dwell time, which is how much exposure the CO2, the laser will have in the skin. And obviously power increases that. Your typical patient as a candidate is a skin type 1 to 3, sometimes 4, but on the 4, you have to pre-treat them, as I will describe. Never do anything 5 and 6. These are the settings we use for the eyes and face when we're doing the DECA. It's included in your manual. It's contraindicated in darker skin, or if there's any acne lesions or wounds or active infections. If someone has a history of melasma, don't do it. If they have any issues with previous lasers or have any autoimmune issues, don't do the laser. One of the things that can happen with CO2 if you're too aggressive is post-inflammatory hyperpigmentation, PIH. So in our practice, we typically pre-treat the patient about a month before. You can either do it with a retinol or a hydroquinone, 4%. Again, it's included in your handout. We start them before, and then, or sometimes we do a nice peel prior to surgery, like a month prior to surgery, especially if I'm doing a full face. So the idea is that you're getting rid of the pigment that's in there. You're increasing cell turnover with the retinols, and the HQ is reducing that melanin production. So that helps prevent it. Now, one thing that I think is magic, this is probably worth the entire meeting, is that I use clobetasol post CO2 laser, post full face CO2, and it really reduces inflammation immediately. I don't send the patient home with them. If they call me 2-3 weeks later and they say they have some redness, I start them on clobetasol at night for a week or 2. But typically it reduces the chances of that. I am religious about making sure my patients wear a hat. And this is a typical, I have a link of this. We send it to them. It's for $16. You got to make sure it's UPF 50 plus, and it's not some knockoff that doesn't have. So a reputable company is key with this. If they develop PIH, I treat it with Triluma, and typically prevention is the best way. It's good sun protection, and if needed, if the Triluma fails us, then we can do a Cosmolan peel, which helps get rid of all the pigment. I have a whole talk on different peels, which you can watch. We'll put it available for you. But in our practice, we use Cosmolan peel. If I'm doing a lower lid blepharoplasty, I typically don't do the peel. If most of the time, if it's skin 1 to 3 or 4, I'm doing the CO2 or a pinch as needed. But if I feel that a peel will help them, I usually do it either before, 1 month before, or a month after surgery. I just don't like, as I mentioned, I like to put the steri strips on if I'm not doing the CO2. Obviously, you can't put the steri strips on if you're doing a CO2 on a patient, but because I want to minimize that swelling. Okay, so I'm gonna go through a bunch of cases, and obviously we'll try to see a little bit of everything. As I mentioned, you will get a chance to come back and hang out with me. If you have questions, you can reach out with me. So let's go. Case 1. So there's a patient who is in her 40s complaining about dark circles. She had lost about 40 pounds and lower lid fat herniation, periocular volume loss, and getting younger. So when we're seeing her,
This is an example of a negative vector eye. So I'm marking the orbital hollow, and she has medial fat herniation, so I want to mark that. But as you see here, there is not much of a lateral fat herniation, so we want to really focus on this area. So when I'm approaching this through the transconj incision, I'm really focused first on opening this area, bluntly dissecting this out from the orbital hollow here, orbital rim, and then not removing any fat until the last minute, and I'll show you. And I do want to build up her cheeks here. So we're gonna bring this out to create this positive vector. You see how much better it looks when I just press on this. So this volume is gonna go up, and then when we approach this way and tighten the septum, the orbicularis fascial plane internally with the cautery technique that we have, it really eliminates the need for anything externally. Obviously, I make that decision during surgery if I need to take a little pinch off here. So same fashion here, I'm marking this fat pad, and it's really just through really gentle kind of dissection. We're not making major changes. She's young, she has nice texture to her skin, it's not thin or anything, and this is the type of patient that's not a candidate for a CO2 laser because of skin type 5. So but we're revolumizing this area. Now, one thing that I want to also mention is that there is a level of hyperpigmentation which is on a skin level, and that's just from rubbing or allergies, and that hyperpigmentation cannot be solved. So the thing that will be solved is and significantly improved is the shadow effect from the fat herniation and volume loss. But the color of the skin in this area will always be that same brown color as you see on the upper eyelids. This is our transconj incision, again halfway between the inferior border of the tarsus here and fornix. Okay, so and blunt dissection. So we make that initial incision as you saw, blunt dissection, and we work our way all the way to the orbital rim. No fat is removed at this time. We're just exposing it. I'm exposing it to see, that. So, and that's the arcus, and you see the tear trough ligament, and we're extending it laterally. And I'm dissecting this. All the way to the arcus expansion, as you see here. You see the arcus expansion all the way in that area, and I'm not messing with it, I'm just leaving that intact. So as we saw preoperatively, this patient has mostly a medial fat herniation, okay? So that's really the key. And at this point, once you have this all laid out and it matches that herniation that we saw in that video, then you can go ahead and start the process of removing some of the fat. Okay, so everything's released and we're now removing the fat. So I'm using the Colorado on a low setting. Usually in our system we use a 19 and 7. And I'm removing the fat with the coag function, so that's important. Again, gently teasing the fat out. Always remember, less is more in these scenarios. I don't want to overdo the fat excision. So if you notice, one of the things that's going on is that my finger here is pressing on the globe just to get a feel for how much fat we can remove. And see, I open this and there's a little bit of fat that wants to come out. Now I feel comfortable with fat removal in this area. Again, you don't want to overdo it ever, but because we're going to be also injecting our own fat, it makes it much safer and much better in that sense. But I'm not a fan of over exuberant fat excision. Okay, so I removed a little bit. I see a little still left here. I'm going to try to tease this one out. Again, we're going all the way to the arcus expansion. Now I want to make sure everything is teed up, so I come out usually, and this I routinely do this, where I come out and pull on the eyelid superiorly, and I want to make sure, do I see anything that's popping out on me? And I see a little bit of medial protrusion here, which I'm going to address. So to release everything, we use a Q-tip, and the Q-tip, again, gently pressing over here, and then I make sure that I see the orbital rim. That's the arcus we talked about. So gentle pressure, and you see the medial fat pad, so that wants to come out. So I'm just removing a little bit of this. Again, if you're very careful with your dissection, you should have a bloodless surgery. One thing we do use is tranexamic acid in IV form right prior to surgery, and that really makes a big difference. So in this area, you also want to look to see if you can see the inferior oblique, which is the, right, separates the medial and the central fat pads. And I see the edge of it right here, and I have we're avoiding it, so I'm pretty much in a safe place. Okay, so be a little bit laterally here. Now, so we've pretty much released everything, reduced some of the fat pad. Now at this point, I want to see how much of the lateral portion here. As you see, because we left the arcus expansion right here, which is an inferior attachment of the lockwood ligament, intact, this area looks pretty tight from this angle, right? And we're in a good shape here. I don't even need to do anything. I don't need to touch the lateral canthus. And you know, it doesn't look any hollow. It looks pretty nice. Now we got the orbicularis, right? So orbicularis is here. And I'm going to deliver fractionated RF. Now remember, this is on a low setting. This is only at 7. And we're going in a circumferential fashion. And I'm delivering this all around the orbicularis fascial plane, which obviously, as you know, attaches to the septum here. So they're kind of one unified front. And what this does, now you have to be very careful, because I showed this to a doctor from Spain, and he called me a month later and he said he's got retraction happen. So you have to use very low energy. And the reason we're doing this in a fractionated fashion is because it allows skip regions, just like you're doing fractionated CO2 or fractionated microneedling. You know, after all, this is a radio frequency, Colorado. So as you see, I'm delivering that, and then I'm coming over here laterally, making sure everything's fine, gently, again, delivering this heat to tighten things up. I may need to release this, and basically that's that. Okay, so I already have injected 2 cc's of fat here, and it's not too much, and I use this 18 gauge for my entry. This is a Coleman 19 tulip cannula. So and the area that I'm replacing is the superficial and deep SUF. So you want to be in deep to the orbicularis in this area, and I go in and then I inject as I draw out. So that's really key. And from here I can really access everything. So I'm accessing the orbital rim, I'm going here accessing that. So I'm just for demonstration purposes, I'm just showing you, but 2 cc's already been injected. You don't want to be superficial with this. And again, every person is different. Sometimes we put 10 cc's here because they need it. So this person doesn't need that much, and that's where we went. Now, if you need to go to this level, you can make a little punch incision here and access the tear trough through that angle.
Okay, so that's that case. Let's look at somebody else. Again, I'm not gonna go through too much, but this lady again has significant amount of you know, hollow. She's got inflammatory reactions around both upper and lower eyelids. She's very sensitive, and hollowness in the temples. But right, I want to just get into the fat component. But the injection of the fat, again, same concept. There's It's a 19 cannula. I'm going deep. I'm going into multiple different levels and planes, and I am with this patient, we even want to get into the temple part of it. So you'll see how I inject the temples with it. But less is more, and that's really the key with all of these things. As you see, my left hand is allowing me to kind of get a sensation of where the blunt cannula is. I'm feeling the position and location of this, so I'm not going superficial, and so that's important. This is for injecting into the temple, again, retrograde, and it's a superficial injection. So you can revolumize everything. Obviously, the nasolabials, you can go if you want to do the marionettes. I don't recommend doing the lips, as you know, generally speaking, the lips don't have any fat in that area. We do inject nano fat into the smoker's line, which I think is really magical, and it makes a difference. But if you're injecting nano fat, you're either using a 25 gauge blunt cannula or a 22 gauge cannula. And if I'm using a 25 gauge cannula, I'm going, again, it's blunt and it's a retrograde fashion. So this is her. This is a patient that, you know, again, we presented early on, and fat repositioning would not answer. She's got maxillary hyperplasia, but hollowness in the temple. So, you know, we went ahead and did an entire fat transfer all around. Again, same concept as everything else. You're going in, you know, this is microfat being injected. With her, we injected close to, you know, I think 20 cc's of fat into her face, something like 10 cc on each side. Revolumize. I wanted to build the cheeks. I wanted to build the tear troughs. I wanted to build the temple, even the subbrow region. And I'll show you, I don't think we have a video of the subbrow fat injection in this, but I'll show you some other videos on how we do that. But the concept is the same. The fat is, you know, I think what really makes a difference is using the micro fat versus the macro fat. That makes a big difference, and staying deep and injecting at retrograde. So as you see, I'm actually getting over the orbital rim, and some of this is going into, you know, into all of that region. Even you know, some of it does get, in a situation like this, even into the orbit, but I'm not worried because, you know, in her scenario, we don't. So people say, when do you release the arcus? When do you not release the arcus? And do you, so with someone like this who's young and it's all tight tissue, I don't want to disturb the attachments. She doesn't have a true tear trough deformity, so it's all, you know, left intact. And I think that's really the key with this, is that you leave things where they're supposed to be. And I'm using multiple different ports to kind of revolumize in different planes some of this fat. Now, if you hadn't done the lower eyelid blepharoplasty in this scenario and the RF circumferential tightening and just went for a fat grafting, the results would never ever be the same. So it's really key. I see this mistake actually done often when doctors just go for the fat grafting without addressing the foundation. As you see, how much are we building? We're building significant amount of anterior and you know, into that area. 30% of the fat goes away, so I never over inject. I think in this video we do show some of this going into the temples. So once I'm done with this, then we go ahead and CO2 laser the patient. So CO2 is the last thing you do. Okay, so you see just from one side how much of an improvement in the cheek and you know, mid-face protrusion you have. So these are visias of her. We just recently posted this.
Temples, cheekbones, mid-face.
So in a nice subtle way, you see significant improvement. We actually have, I mean, obviously other videos of her if you want to see some of that. So this is a patient who actually has, you know, fat herniation, especially, you know, medial and lateral, and she, you know, didn't want to have any skin pinch. So that's the type of thing that I actually document. She also has lacrimal gland prolapse, which she didn't want to address, but we just went in and did some fat grafting. I want to show you the transconj view again, similarly
So as
to
you
case
see,
one.
there's this fat herniation that extends here, and I've come over here. I've made a transconj incision, separated the layers. Basically, the orbic is separated all the way down, and the fat pad is released here, and we go all the way down to the arcus. You see the arcus down here, so that's the arcus. And then I've done this before. I haven't taken any fat out yet, so I've done this all the way laterally. So you see this is a lateral fat herniation, which we'll see on her photos in a second, and then all the way everything's released. So the goal here is not to release, not to open up the orbitomalar ligament, keep it attached, because it's already nicely attached there. We don't need to, and this lady does not have a tear trough deformity. It's mainly a fat herniation issue. And so we're going to reduce this, contour it in a nice fashion, and then I will use RF to tighten the post-orbic, which, as I've shown you guys before, to shrink this internally, circumferentially tighten it for her.
And then once you're done, you go ahead and do the fat transfer like we've seen in
we've
other videos.
Reduced the fat herniation here, both medially and laterally. And now I'm about to revolumize this area with her own fat.
Again, so remember, she has fat, already has nice junction. I'm not putting too much. It's just that I'm just contouring. I'm just trying to bring out, create that extension of the lower eyelid and cheek junction in a nice natural way, without putting too much in there. So it's important to do, and as I mentioned, when you start, you want to do this less is more initially.
It's all retrograde injection. Deep underneath the orbic. That's one. Again, we don't want to do too much on this case.
So this is actually another patient who has significant amount of edema. She's got chronic allergies, as you see, malar edema extending. So I told her she needs to go get her allergies checked. She came in and she doesn't want us to use her full face, so I'm just using this. But again, so I usually do the upper eyelids first if I'm doing something like that. And then there's just a video showing that, you know, in someone who's got, you know, we went and removed some of the fat. So this is after the fat, and I'm going in and trying to create a space where I can do a nice or big suspension and tighten it up in a nice fashion so that direction is towards this way. So I'm, as you see, I put a bunch of Vicryl sutures, 5/0 Vicryls, and suspended the orbicularis that way. And then now I went and cleaned up the skin, and I'm just closing the skin in this way with a 609, few interrupted 6/0 nylons, and then just running it. And then sometimes, because if they have a negative vector, we do want to build.
This patient has proptotic eyes, and I want to bring out the superior, you know, this brow, subbrow fat a little bit more anteriorly. And the purpose is to camouflage this eye popping out, and then we're going to bring this out too.
So that's just the, you know, injection of the fat, usually just 0.5. You're not putting too much fat in here. And just to bring that out, again, I want to camouflage her eyes being so, you know, in a way, just popping out in a very, to reduce that element. If someone has proptotic eyes and you're, especially with the upper eyelids, you're removing skin, sometimes you make them look like, you know, frogs. They look different, so they don't like it because you're making them look worse, actually, in that sense, when you're doing your upper bluff. So in this fashion, we're just putting a little bit of fat and it camouflages it nicely. And all of these incisions actually heal beautifully. You know, we have lasers and things like that. This is a patient who, again, has big eyes. She's got, you know, orbicularis roll. She's got a significant amount of extension of the skin and orbicularis. She's got upper eyelid dermatoclasia. So we did the whole thing, but in a situation like this where I have to actually reposition part of the fat, and I'll show you how I do that. We want to, you know, approach it in a way where the arcus is released, and I go in a, I'll show you this video so it makes it much easier.
So we made a transcondylar incision and released up the fat pads all the way to the orbital rim. And as you see, this is the arcus. So that's the arcus. Pull on this, yeah. This is the arcus, this line. And we're releasing it. We're gonna release this all the way laterally, all the way through. Okay, now I'm releasing this. Medially and all the way laterally. So you walk this out. Want to come all the way. And that's really the tear trough. So this is the orbital malar ligament. We're releasing all of that. And this is an important move when you are dealing with someone with such a prominent tear troughs. So in order to address that, you have to release this. So as you see now, we've released the entire tissue all the way medially and laterally. So that's really key. So everything throughout the orbital rim has been elevated. So I've released everything here, and we're in a subperiosteal level, and I'm gonna suture this fat pad transposed internally here. So we released the orbitomeatal ligament and reduced some of the fat and repositioned it in this place internally. And you see how much of a difference that already takes by releasing the tear trough ligament medially. So that makes a big difference.
But
That already takes.
the video. Then once we do that, then we go ahead and again suspend the orbicularis laterally, and then close the skin, and then go ahead and do the upper eyelid closure, and then do the fat grafting after that. Again, not too much fat. We just want to create harmony in a nice direction towards everything, towards the midface. So those are key factors in this scenario. So there's a patient who actually had a lower lid bluff, and we also did fat transfer. I did the nano stem procedure, which you'll see how we do. So fat is harvested. These are my markings. Want to mark the ribs. Again, 11 blade. I already showed you this. We're removing the fat, liposuctioning it again with the 2 in size 2 cannula. And then once we're done with this, now one thing I haven't talked about is how do we emulsify the fat. And so the microfat is injected. And then
So we have about 20 cc of fat here, which is plenty for this case. Again, every case is different. Sometimes we need more. I'm a fan of less is more usually with these things. I think a lot of the complications that happen with fat injection are when the injector is really aggressive and is over injecting or trying to compensate for things that fat is really not meant to do. I explained, and this is in regards to the microfat, by the way. Yeah, so the nano fat is rich in stem cells, and you can inject as much of that as you want. It's not to replace volume. So as you'll see, it's really just injection with the stem cell that's key with that. So these initial injections that are going into 1 cc cannulas are all microfat, which means we haven't processed them, and you'll see how we process them. But so they're going straight in to replace volume. So I'm injecting retrograde. I use the 18 gauge needle for my pilot, and this is a tulip cannula, 0.9. So I start laterally and massage this in, and I'm going into the deeper compartments. I'm trying to replace like with like, and the fat compartment here is what we're trying to augment. So I'm going into the SUF, the superficial SUF, deep SUF, some of the muscles. And we're bringing the midface up to create a positive vector. And somebody in the OR, it's important that someone in the OR keeps track of how many cc's you put. Although, you know, in a case like this, you know, it's not that important, but it should be part of your protocol that you keep track of how many cc's you're putting in. So this is all microfat. And as you see, that negative vector she had is completely going, and the eyelid junction with the cheek is now, the fat pad is gone, and this has come more anteriorly. So it creates a nice harmony between the cheek and eyelid junction. So I'm going around the orbital rim and injecting in that area. Again, retrograde injection. All of this is retrograde injection.
Then the nanostem, this is the part that basically involves, we go ahead and take that microfat, emulsify it with a 2.4, 30 times back and forth. So you're rupturing the fat cells. As you notice, the color of the fat is changing. And then I go to a 1.4 and go back and forth with it 30 times. And then we go to a smaller one, 1.2. So this is for the nano fat, and then once you do this 30 times, then you want to filter it out. So you'll see once this is done, then we go ahead and filter. So the filter, you place a filter inside that, it's a disposable filter. You put that in and then you close it up, and it has an in sign. So this in sign goes in, that's where you put the fat, and this is where you take the filtered fat, and it's usually a 400 to 600 filter. Now, before I inject it, I go ahead and do a CO2 laser resurfacing. And sometimes I do a Morpheus treatment on the lower face if I need to, but typically it's the CO2 laser. And then once we're done with the full face CO2, then I go ahead and micro needle the entire stem cells in there. Even the upper eyelids we do. So the idea is that by generating heat, you're stimulating the body to repair itself, and it's the repair process that's part of the healing. And not only that, but you're microneedling the nanofat, nano stem cells, which are pluripotent, and they help kind of, change the texture. What's incredible, and this is the nanostem procedure, is that there's something that video does not capture, which is post-op. When you see these patients, they say, my skin looks incredible. Like, what's happened with that? Like, that's the first thing they talk about. And I think, it's really key when you address that. This is our, beautiful patient, and, you see all the things we did. For social media, you don't want to show blood, obviously, so we don't show the microneedling. That's scary for patients. But, that's the whole process. Again, showing it. And this is her, some months after, you see a significant difference. But I want to show nanofat injection actually for dark circles. This patient does have dark circles, fat herniation, anatomical changes. So we did the lower bleph and the fat transfer.
So this is the patient that I just showed you the photo of, but we've done the lower lid blepharoplasty. I've contoured things down. I've done my RF tightening of the septum, so the septum is tightened, and I also dropped about 2 cc of her microfat into the midface region, into the periocular region. Now here's the finishing touches. I'm going to be using a blunt 22 gauge cannula, and I'm going to inject her stem cell. So this is nano fat that's been emulsified through the process that we showed you earlier. And as you will see, so this is the pilot. So again, I'm very superficial, but still underneath the orbic. Okay, so I'm gonna lay this down right here into the tear trough, and I inject as I draw back. So again, this is not a superficial injection. It's right underneath the orbic in this area, and that creates a nice little thing. Now, it's okay if you're superficial, because this is not fat, this is stem cells. So we've emulsified that. And that just creates a beautiful transition through the tear trough that you can't really get. Now I'm gonna come over here and reinforce some of that. I'm going deep now into the SOOF area, and I'm injecting some of this. Again, as you saw, this was very little. This wasn't a lot, so that it was only 0.8 cc on this side that we injected, but that fortifies the microfat with her own stem cells. Similarly, get into that suborbic space, injecting the fat, the nanofat as I'm drawing. And you don't want to overdo any of this. You don't want to be too superficial, but if you get superficial, don't worry. It's because this is stem cells. And that's really the key. Reinforcement, beautiful.
Yeah, I mean, we've shown this patient, so it's pretty magical actually.
And it went like
So one thing about the skin changes is that it starts with the nanofat starts kicking in actually 6 months later. That's when you really start seeing. It's just another video, quick video showing fat transfer to the upper, especially with Asians that are getting older. Volume loss is a big thing.
Reduce that hollowness.
So doing fat transfer to the upper eyelid is really key with them.
Inject the fat into the superior area underneath the brow fat. You don't want to get into the orbit, but get right underneath the subbrow fat, so known as the roof. Okay, and that gives a nice it was just a little.
Right, so that is actually one of the most important things when you're doing Asian blepharoplasty. Look, if I just did her skin and didn't address the hollows that you see superiorly, it wouldn't have been as nice. So we use that all the time. This is our patient you saw earlier, just a quick kind of a thing how she looks. It's just that there's something about, we actually did Morpheus and nanofat with her too.
They feel amazing.
Look at the skin quality.
Confident, and like I look more awake and I feel much prettier.
So definitely magical when you're dealing with that. So one thing that I wanted to mention is that if you're doing lower eyelid blepharoplasty, I think we covered this, but you have fillers in place, you got to remove the fillers. and that's important because they cause blockage of the lymphatics. So this is a patient that we actually removed for a period, usually about 2-3 months before you start removing it. And we combine it with Morpheus treatment to get a tightening effect. And then this is her after her quadfecta, which is the upper and lower eyelid blepharoplasty and fat transfer. And there is no way I would have done this surgery without addressing removing the fillers. If you don't remove the fillers, she would not be this person. How do we treat festoons? This is a gentleman that initially I saw, has significant amount of festooning, orbicularis, hypertrophy, little brow ptosis, upper eyelid dermatoclasia. Our plan with him, we actually pre-treated this. So this is done in a transconj fashion. I want to just talk about the surgery that first, how we approach it. So transconj, somebody will say, well, you got to do a subciliary approach. And I will say, look, with the transconj, I can really address everything. So transconj incision. And then, but before the surgery, I prepped him with, and he's never had fillers, by the way. This is just physiological festooning. Prepped him with Morpheus treatments, a series of them, 1 month apart. And then during the surgery, transconj incision approach, I wish I had a video of this, but I'm going to just describe it. We reduced the fat herniation and then did my lateral canthal approach and did the orbicularis suspension laterally here. Obviously, we did his upper eyelids. We did a direct brow lift on him and then extended the incision here and removed a pinch of skin. But the amount of orbic that was removed here was a lot more than our usual. But again, we want to make sure if I'm doing a lot of orbic removal on someone like this, I want to make sure that I'm suspending everything, tightening it. And we didn't do a canthopexy or a plasty on this case. We just did orbicularis suspension. And then obviously I topped it off with fat revolumization and severe CO2 lasers, so we could be a little hard on the CO2 on this, and then top that off with with nano fat. So that makes a big difference. And so this is him after surgery, something like 6 months after. Look at the texture of skin. I mean, nothing compares to this.
Oh, geez, it makes me just feel so much younger. And I look in the mirror and I'm no longer cringing. When I looked on Zoom, I'm no longer cringing. It's just amazing.
So yeah, the magic of combination treatments really makes a big difference. These are some examples. We don't have too much time. I want to get back to really talking about. So one question we get, common question, is how long do these fat transfer results and lower lid last? I've been doing this for 15 years, and this is a lady who actually came. I did her lower eyelid, and then she came back in 2020. That was 2008. So 12 years later for her upper eyelids. And so the results last a long time. This is a gentleman who 8 years after, and I just want to, let's go back here. Note how 8 years later, he looks younger. Isn't that, so the guy is in his 50s, he looks younger. So fat transfer is incredible in terms of regenerative powers that it has. So regular post-op instructions, antibiotics, ointment, cool compresses. So let's talk about complications, this is important. You have to kind of to top this off. First of all, dry eyes can happen, usually on patients who have a risk of it, and tearing is associated with dry eyes because it's a reflexive tearing. Usually you see dry eye happen on patients who are either predisposed, or if you're doing an upper eyelid blepharoplasty, because as I mentioned before, most of the work is done by the upper eyelids. So other things that can happen is chemosis, and it's usually because subciliary approach to it. You can have some ectropion happen. Is on unfortunate patient who had a subciliary approach to the lower eyelid again. So ectropion is one of the problems. Eyelid retraction again. The negative vector patient, significant removal of fat resulted in lower lid retraction. Canthal dystopia is another thing. So there is an art to this. I mean, obviously you can't just just go and cut everything, try to tighten things. You have to have that sense of art for this. So if you're too aggressive with your approach, again, a subciliary approach, they remove too much fat. We almost don't remove any. As you saw, I try to revolumize even the upper eyelids with their own fat. So that's unfortunate. Obviously, placement of your incisions is really key. Asymmetry is something that happens. Blindness obviously is a risk, as we talked about. So how do we treat chemosis? The best thing to do is have them use artificial tears routinely after. And the first thing I always tell them is, look, the white part of your eye, the conjunctiva, I don't want you to wipe it. If you see tearing, you just close your eyes and gently dab on it, because if you're wiping the conjunctiva, you're going to cause dryness, and that leads to this swelling, which is the chemosis. A lot of times patients wake up in the morning and they see this. Again, note, this is not my patient. This is somebody else's patient. It's just a Codner publication, but you're seeing a subciliary approach here, which is pulling the eyelids down, right? So the way you treat it, lubrication aggressively, and sometimes you have to patch it, and then some, steroid drops do help. And at last resort, you might have to do a conjunctivectomy and release the Tenon's capsule. But that's something that most of the cases they resolve by themselves. This is a case where a patient had patient had fillers, and nobody removed the fillers, and they went and she had this SIBO, which is a small intestine bacterial overload, which she developed significant amount of swelling. So they didn't remove the fillers, and they did fat grafting, and they didn't do a lower lid blepharoplasty. So 3 things. And patient was not happy, came to me, said, look, I look worse, I look horrible, what can we do? And we ended up doing I first had to get her SIBO under control before operating on her. Then we did serial Hylenex injections to get rid of the fillers with Morpheus. She must have had about 6 or 7 Morpheus treatments. It took about 7-8 months, and it was fine because we were slowly dissolving the filler and tightening tissue. And then I did our signature TriFecta with a full face and a nano fat microneedling. This is I actually have a video of her. I don't have this video here. This is actually, they put it in. So you saw the CO2 with the fat grafting. I mean, she wears a lot of makeup, but she's, these are selfies she sent us for follow-up. So she looks pretty amazing. She's very happy. It's really made a big difference. This is another complication that we see. It's actually my own patient, one of my first fat grafting patients that I was telling you. I didn't do his lower eyelids. I just did fat grafting, and he ended up gaining 40 pounds. And as you see, fat grew in that area. It was a good learning lesson for me that, I kind of had to rethink about how I do this. And part of the issue, he did lose his weight, and we unfortunately was that it's very difficult to dissolve this. You can Kybello it, sometimes it helps, and sometimes you have to just do a micro cannula liposuction to reduce that element. This is a patient from Australia who had fat grafting, again without doing the lower lids. And in fact, they didn't address the hollows, in my opinion. They just went and injected fat into her septum, into the orbit, and made her eyelids worse, made the hollowing worse. So I had to convince her that fat grafting with lower lid blepharoplasty and CO2 is the answer, and we actually did do this. And this is her 10 days before she went to Australia. But as you see, significant improvement. Is a patient from Kentucky who had nano fat injection without proper emulsification. As I mentioned, emulsification is key, because if you're injecting microfat in a subdermal tissue, you're going to have lots of lumps and bumps like this. So make sure you emulsify properly. There's a patient from Dubai who had fat transfer without removal of the previous fillers, ended up having migration, ended up having swelling. We had to go in and actually remove the fat surgically. This is the initial patient I showed you with eyelid retraction. One thing that's really important in this kind of scenario is that you never, ever talk bad about another doctor because look, I see everyone's mistake. You name me a doctor, I've seen their problem, and I will never tell you who these people are, because you want to have a good, positive relationship in the community with the fellow doctors, right? Because look, I wasn't there and I was never in. So my job when I see these people initially is like, look, I am so sorry you're going through this. I'm going to try to help you. And I don't know what happened. If you want, I will reach out to the doctor that did this and try to, get some more info. So reach out, let them know. Also, never say, oh, this doctor should have never done this. I see this. I mean, it's a horrible thing that some of these people say because they want to make themselves look better. But in reality, this is something that's not a good thing. But anyways, so what is the risk factor for eyelid retraction? Obviously, as I said, subciliary approach, but there are some preoperative risk factors. If someone's got proptosis, for example, or if they have a negative vector or horizontal laxity, or even tall individuals because they look down all the time. And if you're not addressing the canthus properly, you can have lower lid retraction. As I mentioned, subciliary incision is probably one of the worst things. And sometimes if you're doing septal plication or reset and very aggressive with even RF in that area, you're going to have retraction. So how do we treat this patient? We use 5FU. This is key. If you're doing lower eyelid surgery or plastic surgery in the face, go buy yourself some 5-fluorouracil. I know in some countries, like I was just in London, and I know in Australia, you guys don't have it, but it's something worth getting. Find somehow to get it. It's a chemo agent. The way it works is actually, it inhibits DNA synthesis, but it really inhibits fibroblast proliferation, and that's the magic. The dosage you want to use is 50 milligram per ml. Again, we have this on the handout for you. So what did we do with this patient? So she came in, a 5FU, Q2 to 3 weeks injection in that area. You can inject up to 2 cc's as needed, but make sure you spread it. We have the patient continuously massage up. And this is her after 3 months of just treatment with 5FU. It's incredible. I mean, look at everything. The eyelid position isn't back into normal. We didn't do surgery. Now, sometimes you can use, fillers to fight the eyelid retraction. So that's something been published. There's a paper by Goldberg. He describes using Juvederm in hyaluronic acid in a suborbicularis plane to kind of act as a bolster support, as we were talking about, and that holds the lower eyelids. So this is much in combination. If you do it with a 5FU, it's pretty amazing. But remember, in first place, you don't want to get into this trouble. So the best to not do a subciliary incision. If you're doing revisional surgery, I always tell patients, look, you got to wait 6 months, sometimes 12 months before doing anything. If you jump in too quick when the patient is inflamed, retracted, your best tool is to use the 5FU I told you, and perhaps some HA fillers, but don't do any surgery. Wait until that time. Again, we don't have time to go over the technical challenges involved, but the idea with the eyelid retraction You know, the idea is that you're trying to improve the tensile and bolster support of the eyelid. So, you know, you can do a hard palatal graft, you could do Endorogen, you could do alloderm as a spacer for the posterior. You could do, you know, combine it obviously with anchoring the lateral canthus. You could use a dermis fat graft. Bobby Korn's group, you know, they describe this. You could put an, you know, orbital onlay kind of to help support the bolster. But all of these techniques use a bolster and tensile support. Thank you. I talked a lot. I know we're going to get into the question and answers, and that will start right now. Thank you.
Hi, everyone. I know we talked about a lot of things, and I want to make sure I answer everyone's questions. So I'll stay here as long as we need to go over everything. And if you have other questions, you can please type it in. But don't forget, I'm available to you. If you later on have questions, we can go over them when I meet you in person. So the first question is, what is your opinion about using CO2 for transconj bleph? We have the CO2. I've had it for a long time. I do not use it for this incision. I find that the Colorado is much easier. The CO2 has a big bulky handle that's, you know, you have to sterilize. So it's just easier. The Colorado is much better. Can you excise? The second question is, can you excise fat as and then fat grafted while you're removing the fat from the lower eyelids? Can you just use that to revolumize? And the answer is yes, you can. And actually, that technique is called the fat pearls. It's something that's been used for a long time. The issue with it is that sometimes, because these grafts are, you know, too big, they're actually bigger than macro fat, and they can form cysts, and they can form, you know, cause necrosis, which is not a good thing. We don't want that to happen. So fat necrosis is really the key with it, any of these things, but you certainly can use them if needed. What is the setting of the RF assistant on your Colorado? I think I answered this, but you're using the coag portion at around 7 to 8. So it's got to be very low. Can you please go over your overall treatment strategy for Cliff? Okay, so as you remember, Cliff is the chronic low-grade inflammatory induced periocular hyperpigmentation. Actually, this is a case series we're publishing. You know, these patients are, you have to remember, these patients have chronic allergies. So the allergy component needs to be addressed in part of your treatment. But we're starting to see that when you inject nanofat into the subdermal area, the results are pretty amazing. And, you know, I showed you a couple of examples of that, but you're basically using a blunt cannula and going right under the orbicularis and over it. But again, you have to make sure if you're doing nanofat injection that you emulsify this significantly. So we don't want any fat present. And as I showed you in some of those complications, they didn't emulsify enough and there was fat present and they got a bunch of issues with that. So the next question is, can you please go over your, so let's see, the next question is about fat transposition. So when do you fat transpose the fat? And so I'm sorry, actually that video had a section that broke off, but so think of it this way. If a patient has a positive vector eye and pretty much no volume loss here and a true tear trough deformity, I go ahead and release the arcus over that
medial section, and then reposition the fat pad. And I use a 7/0 Vicryl to internally attach it in a subperiosteal fashion. So that's the key. And then you saw in that video, I actually went and did fat grafting on top of it. So you can do fat grafting. The problem I see with a lot of people who are doing fat grafting, there are two issues. One is that they do the fat grafting first and then they reposition, which is not the best idea because you want to start deep and then come out. And then a lot of times they put too much lidocaine, and there's another question about, can you do this under local anesthesia? And the answer is you can, but the problem is you have to put too much lidocaine that distorts the tissue. As I said earlier, I also think that lidocaine will affect the way that fats survive long term. So I'm not a fan of doing that. So that's important. But if we're moving, so if you have on extremes, a positive vector, that's the part with a true tear trough deformity is the part that I transpose. And then as we move towards the negative vector, I want to debulk the fat pad and always suspend the orbicularis. And I suspend the orbicularis with a 5/0 Vicryl, as you saw. It's buried. And, you know, even if, so some other question came about, well, it seems like TriFecta is better for younger patients, but the answer is no, we do it on everyone because we're addressing all three elements. So the position of the lacrimal, the lateral canthus is key with that. So let's go to the next question. So we addressed fat transposition. There was another question on that. There's a question, I think that was early on, about the pinch. So yes, we do. The pinch involves extending it. Again, it's just a pinch of skin. So if I'm doing a pinch, I always do the lateral canthus. I want to suspend the orbicularis. I used to do a, canthal tarsal strip procedure or canthoplasty. I find there is no need for it, even on some cases when the patient is really old or has significant amount of laxity. I don't have to. I find that the orbicularis suspension technique I have creates enough of a bolster support to, in a natural way, hold things together. So it says, so let's see. So a lot of questions about repositioning, and we answered that. Have you ever seen lumps from nanofat? The answer is yes, if you're injecting not true nanofat, but non-emulsified nanofat. So as I mentioned, that patient from Australia, we actually did a full high-level CO2 laser resurfacing to address that issue if it's superficially placed. When do you associate orbicularis suspension and canthoplasty? Okay, so I think I answered this question already, but I honestly don't think there is a need for a tarsal strip. There is no need for it. I think it's too aggressive. It can lead to canthal dystopia, and the orbicularis suspension technique is enough to address the bolster support and the tensile support we were talking about. Let's see what else we have. Have you ever seen, see, when do you associate orbicularis? Like we talked about this. In the hollow, do you normally fill it with nano? So if somebody's got hollow eyes, so there's a big difference between microfat and nanofat. As I mentioned, microfat is what we use for volume, and nanofat is for skin texture and reinforcing with the use of the just bringing in the stem cells, as we talked about. Hello from Thailand. Hello. Any comments surgically for Asians? So we talked about, I think, now Asian upper eyelid blepharoplasty is a whole different topic and it's a long conversation. But the key takeaway that I will tell you is that you should incorporate fat transfer to your upper eyelid with Asians, especially Asians that are older. And I find that it's magical. It's incredible. It really changed the way you're doing things because with Asians, we want to have a full upper eyelid, and it makes a huge difference in that aspect. And I showed you some videos. Another question from patients with substantial pretarsal orbicularis hypertrophy, do you employ a additional surgics or non-surgical? For sure, if there's a orbicularis roll, and this is interesting, actually, the timing of this question, because a lot of my Asian patients love to see the orbicularis roll. They love it. And if you go to Korea, they inject HA into that area. So, but to address the older patients, we certainly take a little pinch of skin, and I find that helpful. And for sure, if needed, we can inject some Botox, micro Botox to the pretarsal orbicularis. Can you talk about HA fillers in your consultation? Do you think who's a candidate? What do you prefer? So, wow, that's a whole discussion. I will share with you one thing. We actually have a publication coming out next week, I think, on ASJ, where we documented blockage of the lymphatics with using an ICG dye. We documented for the first time that if someone's has fillers in the midface, even if it was 15 years ago, that the lymphatic is completely blocked. So that's very important. So I am in the big picture, I am not a fan of HA fillers in this area. I can tell you that we're working on something really exciting, and that's from your own body at point of care. The problem with fat transfer is that you have to have surgery. So I'm really excited about this new thing that we're coming, that we take the blood and we process it in a way, and we're seeing that it lasts actually 6 months, which is great, and it's autologous, but we'll hold off on that. So am I a fan of HA fillers? Look, few things. HA fillers will have a role, I think maybe around the lips, on the lower face, they're fine. I'm not a fan of them in the mid face or tear troughs. I think in the big picture, their cross-linking causes inflammation. The cross-linking migrates. It's something that we're sold as this thing is going to last. It only lasts 6 months. But the issue with the HA filler in that area is that if you get it post-septally, and as I mentioned, by the way, with the lymphatics being unique, as I mentioned, with the malar septum being unique, that's an issue. So in the big picture, I am not a fan of them, and we actually stopped injecting HA filler to the tear trough, and because I have a better solution for it. But if I was to use HA, I would use the Restylane Classic. I think that's got the least amount of cross-linking, and Galderma branded it, as you all know, as the iLight, but it's just the same thing as what it used to be, which is a classic. If you're approaching HA filler injections to the tear trough, you should at first address the midface. And my filler of choice, again, is radius, but radius not injected into the soft tissue. You have to be careful. You don't want any radius in the soft tissue. It's over the bone. So I use a blunt cannula, and I make sure that the tip of the cannula is right over the bone as I'm injecting it. So for me, that's a much better thing. Radius, as you know, you can't get rid of it. If you get it in the tissue, it becomes an issue. Radius and Sculptra should never be injected around any muscle that is circumferentially mobile. So those are key things to talk about. But I am not a fan of HA fillers in the tear trough long term. So how often do you find yourself pursuing a second lipoaspirate for patients with suboptimal fat transfer? Great question. I think, I tell patients 30% of the fat goes away. In the past 15 years, so I never over inject. I always try to, as I mentioned, less is more. And I also think that these results last a long time. I used to tell patients that this lasts only 5 years, and I still tell them sometimes because I don't want to ever over exceed anyone's expectation. I usually actually avoid the topic of how long anything lasts. I tell them, look, aging is a continuous process. It depends on your, how you age and your genetics. But there are times that we have to go back and do that. And I would say probably maybe in 5% of all the patients I've done, I've had to go back and redo it. Sometimes we just go ahead and put some radius on board, and it's great. It works fine if needed. As far as the list of instruments, we will have that for you. We'll send it to everyone. Have you ever seen lumps? We talked about this. We talked about, so this says for medial cheek volumization, do you also volumize the deep fat pad? And the answer is yes, we do. So the technique I use is actually called FAMI, which is fat autologous muscle injection. It's a technique that was first described by Roger Amar, who's a Spanish, I think he's retired now, Spanish plastic surgeon. And the idea is the problem with the initial fat injections were that they were superficial macro fats that led to lumps and bumps and unpredictable. So by being able to inject microfat deep into the tissue in a retrograde fashion, as I described and you saw, in multiple different planes, you are now allowing the microfat, to have a bed of tissue, which has great blood supply and is not superficial, whereas could lead to lumps and bumps. So that's the answer. And to answer your question, yes, we go in multiple levels to do that. It says to clarify, when you say 19 and then 17, we presume setting cut equals 19 coax 7, and the answer is yes. That's for that. In patients with giant eye bags, do you do same technique as you showed? Yeah, so somebody who's got giant eye bag will require a lot of removal of fat. So it's not a one size fits all. Do you release the orbicular ligament before you do lipofilling? Only if the patient has true tear trough deficiency. But on most patients who don't, then I don't. How much IV tranexamic acid? So I really think tranexamic acid is actually wonderful. If you're not using it, you should. We inject 1 gram of it, and it's very cheap. It's a cheap medication. So 15 minutes before you start. So what's your opinion about mid-face lifting through a temporal approach over a SUF lift transconj to revolumize the mid-face? So I think a mid-face lift plays a role if someone is if we're doing a brow lift and we're lifting it. But the issue with it is that, the approach has to be from this approach. And we have a whole different thing that we can talk about. That's a long discussion in terms of the surgical technique. But do I think a SUF lift in a transconj approach works? We used to do it. I don't think, it's something that I would recommend. As I mentioned, I'm trying to think like, when would I want to do a SUF lift? So if someone has significant amount of malar bags or festooning like that gentleman you saw, even with the transconj approach, I tighten everything, but the orbicularis suspension, I do remove some orbicularis muscle laterally and suspend it with a bunch of fibrobicros. And so I don't feel that I need to address the SUF in that fashion. There's no need for that. And when I go ahead and revolumize that area with the fat, it makes a big difference. So I hope that answers that question. But I don't think SUF lift I think it's an old technique that's kind of gone out of style with a lot of doctors. Let's see, what else do we have? How do you handle a very deep medial tear trough? So as I mentioned, deep tear trough, I want to release the tear trough ligament. I want to release it. And if it's really deep, I reposition it. So those are patients that need it. How do you handle lateral tear trough? Do you use lipofilling? So we talked about this already. Do you deliver RF assisted tightening transconj? Yes. Everything is transconj. As you saw, every patient, no matter how old they are, we use a transconj approach. At what depth do you apply microfat to the tear trough anatomical plane? So microfat is injected deep to the orbicularis if I'm going towards here, and if they have a true tear trough deficiency, then I release it and I lay down. I mean, if I need to transpose, I do, but if it's something in between, then I put the microfat in there. So it's deep to the orbicularis, and you can get into the orbit. It's not a big deal. So during the TriFecta technique post-op period, use lymphatic drainage, radiofrequency ultrasound. If you do, when do you use them? No, I don't. I typically don't do any Morpheus to this area, even at a 1 millimeter, by the way, post TriFecta for at least a year. And I find that most people out there are using the RF in a very high setting, and that can have a lot of negative consequences. So you have to be careful with those kind of situations. So a lot of questions about releasing, repositioning. So what suture do I use? I already answered that. We talked about transposition. Okay, so one thing that I'm sorry got caught off was, which I want to take like 2 minutes to go over. So once you liposuction the fat, what do you do with it? There are different things. Some people spin it, and I actually have a beautiful paper for you that reviews all of this. It reviews what are the what do you do with the fat, and it talks about what's beneficial. The answer is where you harvest the fat. Usually it's the abdomen flank region. You can go from the knees, you can go from the thighs. So that's where you harvest it. And then the tumescent that we use is typically, I use a 15 to 30 of, so the ratio is saline, it's 1:3 to 1:4, which means if I'm doing for example, I do a 15 of, and this, by the way, will be in your handout, so you don't have to worry. But it's 15 of lidocaine, 1% with 1 in 100,000 epi, and 45 of normal saline. Now you can double that, and some of my colleagues actually do less. Again, the amount of tumescent you need for this is not much, so it's not a huge number. The second thing is, so you inject the tumescent. So let's say I'm doing a quadfecta. I'm doing an upper lower fat transfer CO2 and an antisamber, the whole thing. When I do the right side, I go ahead and inject the left side. Then I'm waiting for this to happen. It's the time for me to go ahead and inject the tumescent. So I inject the tumescent, and while I'm going in there, then I could do this left side, and tumescent is taking effect. Then I go ahead and, as I showed you, take out the fat. I don't spin it. If you want to spin it, you can, although we have the system in our practice, but we stopped doing it. You can spin it. For the Coleman system is 3 minutes. at 3,000 RPMs. So if you want to do that, you can certainly do that. I personally feel, although I have tremendous respect for people like, look, Tim Martin, which is a friend, a colleague from San Francisco, he does beautiful surgeries. He spins it, and we've had an argument about this many times, that he thinks that you have to spin. And I've talked to Ternard, who doesn't spin. I don't spin. So these are just the way it is. And I think keeping things simple is the best. I also think when you spin it, it's possible that you may damage the fat, especially for the microfat component, which I want the fat cells to be as viable as possible. But again, beautiful results by incredible plastic surgeons who spin. So, and I also find it that spinning becomes a bigger issue if you're doing a lot of tumescent, if you're doing a lot of liposuction, meaning as an adjunct, you're doing somebody's liposuction, which requires a lot of lipoaspirin, then that becomes important. But if you're focused on it, you don't, in my opinion, you don't have to spin it. So those are the key things about that part of it. And but you can read those papers. Make sure you read them. The future, no doubt, is nanofat and regenerative powers of these things. So let's see. Do you close your transcondylar incision? No, I don't. And the reason I don't is because I want those lower eyelid retractors that I mentioned to kind of stay where they are. And there was another question actually to prevent any retraction from happening. And I find that there's just no need for it. I've never done it, and there is no need for it. Another question was that if you're doing a lot of fat grafting, do you sometimes feel that you have to close it? I've never seen anything like that. And in fact, I've never seen fat come out of this area. So don't think that's an issue, and we have to worry about that. It says, can you explain your orbicularis suspension technique? Basically, as you saw in the video, right underneath the lateral canthus, you make the skin incision, you remove a little bit of the orbic if needed. If you don't need to, then you don't. And the idea is you're putting a buried suture with a vicryl to bring the orbicularis laterally higher. And as you know, vicryl will absorb, and then you close the skin with a nylon. Do you microneedle the fat? Yes, we do, as you saw in the video. So let's see, which CO2 lasers? We already talked about that, and it's in your handbook. Do you have any consideration for fat transfer in premenopausal women? No, I don't. I don't see that as being an issue. What plane do you inject the fat? We talked about it. Into the SUF, deeper into the muscles. Do you use 5FU diluted? No, I don't. It's pure, and actually it's in your PDF handout, so you can see that. What sutures we talked about? Colorado parameters we already talked about. Can you talk about settings for Morpheus festoon treatment? Okay, one thing about Morpheus and festoons. So Morpheus is radio frequency, good to treat filler associated. We actually have a paper we just submitted on how you treat this condition, which is called FARI. So it's wonderful if someone has lots of fillers here and you dissolve it and you use Morpheus. So they respond the best. However, for someone who's got regular festoons, I pre-treat them before surgery. So it won't be the answer in terms of solving their festoons. However, you can use some Accutide, you can use Morpheus, and I go deep in this area from 3 to 1, and I stack them. So and the power range is between something like 25 to 30. So I think this question by Paul Phelps was about the settings we use on that. But the reason I say this is that it's not going to solve, festooning, because you have to bring the other elements, which means sometimes you need to do surgery on them, like that patient you saw, because no Morpheus would take care of that person I showed you. So in the future, if there's volume loss, how do you address it? As I mentioned, radius I think is great over the bone, but you can use Sculptra, again, not around the tear troughs, and I'm not a fan of HA fillers, so that's that. So let's see, does dosage and timing of IV. So as I mentioned, for tranexamic acid, it's usually 15 minutes prior to your surgery. On the operating table, besides looking at the pre-op photos, how would you control the symmetry? Will asymmetry ever been an issue if someone would like to address it post-op? So I'm not clear on what this question means. So I've already marked them standing up. Don't forget, like on all our videos, I mark the patient standing up and they're awake before they go to sleep. So asymmetry is so I mark them, and I also have their photos in the operating room. So I address that way. But one thing about asymmetry, just to kind of put you at ease on this issue, is that I always tell patients, look, you have asymmetry, and most of us have it. 99% of patients are asymmetrical, and I show them during that consultation period, and I tell them, look, sometimes asymmetry is because the bony changes or the way your eyeball sits with the rest of the tissue. That's why your exam is key during that time. Another thing is that sometimes asymmetry is because of a ptosis or because of a brow ptosis or certain things that I can help, maybe deflation on one side versus another. So we can address soft tissue changes, but we can't address bony changes or underlying eyeball asymmetry. So that's really key, to have that kind of conversation with your patients beforehand. So how do you reposition the lacrimal? It says duct, but it means, I'm sure it means the lacrimal sac. So I usually just open up the lacrimal gland when I'm, so left incision, I open up the septum, get into the preaponeurotic fat, kind of gently expose the lacrimal gland, and then I use a vicryl suture, a 5-0 vicryl, and I get the anterior edge of the sac, and I go attach it to the periosteum. So that's a buried suture, and then and that's really the key with it. There are a couple of them sometimes you need, and it's beautiful. It lasts forever. It doesn't come back. So that's how we do this. Can you use machines for regular liposuction? Yes, you can, but you don't have to. With your orbicularis, we talked about orbicularis suspension. How do you combine Morpheus 8 and CO2? Look, we actually have a course. It's called Maximizing Morpheus. And if you want, it's available online anytime you want to. If you have a Morpheus, I highly recommend taking that, because I go over a bunch of different cases. I go over settings. I go over things. So it's available to you anytime you want. So harvesting the fat, as I mentioned, we usually go from the abdomen. You want to make sure when you're doing it from the abdomen, check for hernias, or the flank region, and sometimes the buttocks or the medial thigh. So that's the key. Can you share the protocol for patients with edema? Clarification, if it tends to remove more fat, negative vector, we talked about that. So let me see. Yeah, I mean, look, edema is a multifactorial thing. Sometimes it's due to inflammation. And, Babak Marar has a beautiful paper that looked at rats who, they have an animal model of rats that once they knocked out the T cells on these rats, they never produce any edema. So there's actually a clinical trial on use of anti-inflammatory medicine to treat edema. So it's a big deal when you're doing breast surgery and breast cancer treatment, because they develop this chronic edema. So that's the trial for that. But so malar edema, again, is this subtype of it. And as I told you, anatomically, this area is susceptible for it. So you have to get rid of the inflammatory component. You have to get rid of the fluid retention component, and you have to reduce the fluid overload component. So these are all things that are part of that treatment. So we tell patients, sleep on your back, cut down on salt, control your allergies, do jade rollers. Do these things work? The answer is yes. In fact, there was a patient who called our office. This is actually, I have to share this case. I don't have her photo here, but I saw her. She calls up one morning. Her face was all swollen. She goes, "Okay, I need to go see Dr. Parcel." My friend thought she had to wait a year to see me, and her friend said, "Look, he told me to follow this protocol for fluid retention, and you should do this." So she went on a deep dive, hired a nutritionist, started cleaning up her diet, went on gluten, all these different things, dairy free. She came back a year later, and I walked in and I looked at her. I said, "Okay, this patient doesn't really need my help." In my head, I'm thinking. And then I sat down, let's make a wish list. And she goes, "Dr. Parsa, I just want to tell you, I came here, I want to share with you. I saw this is me a year ago. This is my photo. You see, I was thinking, I followed your protocol that you share with my friend, and I went and hired a nutritionist, and here I am today. I don't have any fluid or I don't have swelling. You really helped me." And I said, "Wow, this is incredible. You had nothing, no surgery, no nothing." She goes, "No, I didn't." And she goes, "But I just wanted to come in and show you this. And if you want to do Botox or whatever, I'm really happy with this." So the moral of the story with that case is that a lot of times fluid retention is a big part of what's going on with these people. So I'm a big believer that diet is important, lifestyle is important, allergies and immune reactions are important. And if you answer them, address them, it's key. So we talked about, it says clarification, if a cannula or needle is used for injection. I know Tonard describes the sniff procedure, or let's talk about that. So here's the thing. Look, if you're injecting the nose, the glabella, the forehead, number 1, 2, 3 causes of blindness. With a needle, you're gonna get in trouble. So I know there are a lot of people who are using that, but if you're just to minimize the risk of blindness, don't inject these areas. And if you're injecting them, I just say don't inject them. Now, these deep lines, sometimes I inject, but I'm using a blunt cannula. It's either a 25 with a nano fat, and it's a blunt cannula in a retrograde fashion. So that minimizes any kind of a thing. And I know that Tonard uses a needle around this area for smokers' lines, and that's fine. This area, you may have some occlusion. Again, you got to make sure that you emulsify things. There was actually a case of recently of blindness in Los Angeles that happened using a PRF. So it was just PRF. It wasn't even something, more than that. So the embolic event can happen, and you can minimize it by using a cannula. That's what I believe in. I hope that answered your question. Do you think that a higher conch incision for entry is an issue? I'm higher than your incision. Also, orbicularis roll. Does the orbicularis suspension deal with that? So the reason I make my incision halfway between the inferior border of the tarsus and fornix is because sometimes we do a pinch, so I want to have good proper blood supply. I also don't think that you need to approach it right underneath the tarsus, because that can lead to malposition. So this avoids multiple things the way I approach it. So that's that. And then in terms of the orbicularis role, as I think Danny asked this question earlier, and if you are doing a lateral canthal orbicularis suspension, and the patient has significant amount of orbicularis roll, you should take a pinch off in that area, and that minimizes that. And sometimes you have to use Botox, as we talked about. Wow, we have about 100 questions, so I'm gonna go. A lot of them are repeat questions. Do you ever use lipo-assisted vacuum? No, I don't. We have it. I don't use it. I only use it if I'm doing a liposuction from the submental area. But again, I would never liposuction. This fat is not good for re-injection in this area, just for you to know. When you're doing a lower art, so let's see. Do you have a reference on the use of orbicularis for tightening of the orbicular muscle? Could you use this been done with our waist device? Actually, I haven't published this technique. We're going to. I'm gonna publish it in a book, so we're working on that. But I don't have any outside reference besides the fact that it's fractionated. It works. A lot of questions about repositioning versus that. We've answered all of these. Have you ever had the occlusion complication with fat grafting, and how treated? So knock on wood, I've done probably 4,000 fat grafting in the past 20 years. Never have had an occlusive event, and I can bet that I will never have an occlusive event from fat grafting because of what I told you. I use larger cannulas, blunt, retrograde, and that's really key. I'm not concerned. I avoid areas that are really danger zones with which can be a significant problem with blindness, obviously. But I've never had any of that. I've had, as I told you, fat grow. I've had, I've told you, fat can necrose initially if you're using macro fat. So I don't use macro fat. So we talked about CO2 resurfacing. It's actually on your handout. Again, we have another course called the Morpheus, Maximizing Morpheus, where I talk about the duplex treatment, which is a combination of Morpheus and CO2. Do you use a fully ablative fractional CO2? The answer is so fractionals. So CO2 by definition is an ablative laser because you're burning the skin. The difference between ablative versus non-ablative is that non-ablative lasers, such as your Fraxel, they use specific like 1540 wavelength to attract. They basically attract either hemoglobin they're using, or attracting water that heats up the tissue and does not burn the superficial skin. So ablative is when you're burning. So CO2 is an ablative laser. So is your YAG laser. So fractionated means it's skipped areas. And one thing, as I mentioned earlier, don't use CO2 on patients which are darker skin. You're gonna have hyperpigmentation, and that's a major problem. So those are key things. So basically, fractionated means we have skip regions. The subconj incision is not closed. Are you using, what are you using for your microneedling? It's actually, it's a device that I think I included in your handout, and if not, I'll make sure that we have the name and where you buy that device. What is the best time to start 5FU after retraction? Early. So first thing you do when you see a patient who's got retraction, inject them with 5FU. In fact, if you see someone who's got any lumps forming, don't inject steroid, as that causes a lot of atrophy. I'm not a fan of intradermal steroid injection for that. 5-FU is a magic treatment for any of these inflammatory reactions. Even if you have a patient who has a filler-induced inflammatory granuloma, 5-FU is your answer. Do you ever have patients with a history of under eye fillers and fat herniation that you proceed with dissolving filler and do Morpheus as part of your pre-trifecta treatment? The answer is yes, we do. So we get them ready. Basically, if someone has fillers in our practice, which is a big bunch of them, I start them through a protocol about 2 to 3 months before that we start dissolving, and bring them back every 4 to 6 weeks. And I sometimes combine it with Morpheus because I want it to tighten prior to surgery. So that's really the key. And if you want the Morpheus course, we have that all in details in our link on our core aesthetics link. I think this is the last question. What do you do for post-op pain discomfort? The only thing that's painful post-op is the CO2 component, and that's only an initial-ish period. Do you allow, and usually by initial, I mean really like 4 or 5 hours. So cool compresses make a big difference. We also have a mask sometime we have them get. I never, ever give patients NSAID post-op. I just want you to know you're doing orbital surgery. Lower eyelid blepharoplasty is orbital surgery by definition. And anytime you're getting into the orbits, you don't want them to have NSAIDs. It's not a big fan of it for a week. So Tylenol is the way to go with that. At what depth is fat grafting placed? In the temple. So it's superficial, right? So you don't want to go into the deep temporalis because, again, very tight space. And if you're getting in there, you can have compartment syndrome where you cause an occlusion and that becomes a problem. So superficially, very important, superficial injection. All right, guys, I think we got all your questions. Let me see if I missed something on the chat bot section. That's it. We're done. Thank you, everyone. Appreciate every one of you. I'm looking forward to meeting, hopefully, you guys soon sometimes. If you want to schedule, you come in, you have to let us know early. You can reach out to us through social media or email. My email is kamiparsa@gmail.com. Although the best way to reach me, probably to make sure, because sometimes I get emails and I don't respond to them for a long time, social media, and they will let us know. We'll go from there. Blessed. Thank you. Big love to everyone. Enjoy the rest of your week.